Yes. Okay, good morning, everyone.
Hi, good morning. Is the YouTube live is still not on, I think.
It's
working, no?
It's working?
That is showing live YouTube.
Yes, it's coming. Yeah. It's on. It's on. Maybe the link is different. I have to check. It's showing live actually. But can you just check on YouTube once?
Yeah, I'm opening the YouTube. It didn't load. I'm reloading it. Just came in.
Okay. Okay, so it is showing live actually. We are also live on YouTube at this link. I'm just sharing the link just in case if you want somebody to use it. Good morning once again. We are here to learn more about cancer, cancer treatment, cancer incidences, risks for cancer, how we actually can know more about it and be ready to fight it if it comes to our dear ones, near and dear ones. We have a very wonderful line of speakers today. Just give me a minute. I'm going to share this. I thought it was going to be shared. Starting from Dr. Ajay sir, who will be, yes, starting from Dr. B.S. Ajay Kumar, who will be giving a keynote address. He'll be joining in a few minutes. And then we have a round of, again, experts, practitioners from different hospitals, including Fortis Hospital, Dr. Sandeep Nayak, then Dr. Madhu from Kidwai, Dr. Vijay Pillai from Narayana Health, as well as Dr. Swapnil ma'am from Apollo. So while people join in, I would like to give some context, that most of you are already aware of, but just to sort of see the statistics on the ground. 2020 numbers are out. 2021 is not yet out on the Globocan WHO website. Breast continues to be the top cancer of incidences across both sexes, and then lung is the second largest. When you look at male cancers, lung cancer is the top cancer, followed by prostate and colorectal. Yes, in females, breast continues to be the top cancer. And as many of you know, at Niramai, we are addressing this largest cancer, which is causing the largest number of cancer deaths and cancer incidences in women. Over 500,600,000 plus women dying every year, 2.2 million women getting cancer every year. This is huge. And how can we fight it? How can we address it? By enabling regular screening and early detection, early intervention. That is the only way to actually catch and fight any cancer. And at Niramai, we are very, very focused on addressing one big cancer for women, which is breast cancer, as you all know. And many of you know that we have actually developed this new method of detecting early abnormalities in the breast, including cancer. And with this, we are able to detect cancer much before a lump is felt, much before a symptom appears, almost stage 0, stage 1. And our test actually works on women under 45, above 45, and even men can also get breast cancer, though the statistics is much lower. And because it is a very simple, non-contact, non-invasive test, which is safe and also very simple to use, where nobody sees or touches the person, more and more women can actually adopt this at their nearest center, or even at the comfort of their homes. And it's a very simple test where the lady just sits in front of the device for about 10 minutes and, no pain, no compression, no radiation. And simply the report will be ready. The report will be reviewed by a radiologist, and it is a very, very novel solution made in India, which has about 30 international granted patents around the world, where we convert the temperature distribution, just the skin temperature distribution, 4 lakh temperature points are converted into a breast health report. Yes, it is clinically validated. Over 33 international peer-reviewed publications have been published. It has been found to have very high levels of detection of cancer capability, which is sensitivity, with very less false positives as well. And it is regulatory cleared in multiple countries, including India, multiple countries in Europe, Philippines, Kenya, Dubai, Abu Dhabi, that is UAE, as well as, of course, we have a device which is approved by US FDA as well. We have now close to 1 lakh women who are screened with our test, and it is commercial in multiple cities, and as well as very, very top hospitals as the ones you see below, Apollo, Medall, NH, HCG. All of these have been huge supporters of this particular technology and a test, and these are all available in many, many hospitals, including the ones listed here. We have also conducted many rural camps working with different government institutions, including Karnataka government, AP, Telangana, as well as, very happy to share that Punjab has now adopted this as a screening test for the whole of the population. Now, 8 districts have already been covered, and we are going stronger and covering the rest of the districts as well. All this is impossible with so much support from all of you, from the doctors, the collaborations with our customers and partners, as well as wonderful, recognition and incentives we have received from the world around us, the ecosystem around us. We were the winners of the Commonwealth Digital Health Award in NCD category. We were the winners of the National Health Award in the diagnostic category. We were also awarded last year the World Bank Award in Women Health category. This was awarded in the Consumer Electronics Show at Las Vegas. Also in France, MedFit, as well as Eurasante programs have selected us to be the top emerging technology in cancer. And also Primary Health Tech Challenge, which was conducted as an international competition, across multiple socially concerned organizations. And, this has only made us much stronger. And as a team wanting to solve this problem, at a more affordable and accessible manner, so that we can make this available to everyone. So if you know any, even a socially concerned organization like a nonprofit, we can work with them to give it at a very, very low cost price kind of a thing. So many, many more women can benefit. Any hospital or a diagnostic center nearby, if they don't have, please let us know, and we will be able to provide this test there. And please take care of your health. Take my breast screening test or any other breast screening test every year, and detect any abnormalities. The only 2 things can happen. Either you find an abnormality or you won't. If you find an abnormality, it's going to be so early that you can actually go back to work within a few months. If you don't find, it's great, you're healthy and you can have a peace of mind and come back after a year and make sure that you can continue to be healthy. So with this, I would like to really urge everyone to collaborate and fight this huge disease that is taking on the world now by knowing more and staying aware of these cancer-related issues and screening every year and staying healthy. So with this, I would like to sort of invite our speakers to talk about the different deep aspects of cancer, not just breast cancer, but many cancers will be covered today. These are experts. You should actually come forward and ask your burning question or get more out of this. It's very, very hard to get such specialist time for us. They're so busy saving people, saving lives every day. And we're very glad that they've agreed to come in and provide us the knowledge about this. And please make use of this next 2 hours and yeah, just one second. Yeah, benefit. So Shiva, can you put on the other slide? Yeah, I'll stop sharing. Just a minute. Dr. Ajay is having some difficulty joining. Yeah, he can join now. I've disabled registration. He can join now. Yeah. Sorry about. Yeah. Sure.
Hello.
Yes, yes. Dr.
Rita, can you hear me?
Yes, sir. Yes, sir. Dr. Ajay Kumar has joined us. We are very, very pleased to have you, sir, to address this gathering. Dr. Ajay Kumar needs no introduction. Dr. Ajay is the executive chairman of HCG, Healthcare Global Enterprises. He actually is the founder of HCG, which is very, very famous for cancer care. And his vision is to kind of, make advanced cancer care really accessible to everyone. He's been the driving force behind HCG's growth since its inception. Dr. Ajay Kumar's contribution to the field of cancer care in India and his success as a first-generation physician entrepreneur has been widely recognized. It is very rare that you find a doctor being an entrepreneur, starting, hospitals, starting cancer care and things like that. And he has actually written a wonderful book, explaining his experience and learnings. And, it's a huge inspiration for all of us. I really encourage you to read that. He has been awarded the Ernst & Young Entrepreneur of the Year Award, Asian Healthcare Leadership Award, the CII Regional Emerging Entrepreneurs Award, and the BC Roy Award by the Indian Science Monitor. Dr. Ajay Kumar, sir, is also the recipient of the Karnataka Rajyotsava Award, which is a state award given every year. Dr. Ajay Kumar has been a practicing oncologist, both in the US and India for over 3 decades. He completed his residency training in radiotherapy from the MD Anderson Hospital and Tumor Institution of the University of Texas, and his residency training in oncology from the University of Virginia Hospital. He received his MBBS from St. John's Medical College, Bangalore, and Dr. Ajay Kumar, among other things, saving so many lives. He's also an avid marathon runner, trekker, and a voracious reader. We are very, very glad to have you as a part of this session and to deliver the inaugural keynote, sir. Over to you. Thank you so much.
Thank you very much, Geeta, for this wonderful introduction. And I just want to really say on this World Cancer Day, I want to start by really congratulating Geeta and her organization, Niramai. I have known that Niramai for a long time, and how as scientists you have really put in a lot of effort and how you have focused on early detection of cancer, which is very important to say today, particularly your non-invasive device, how portal, how it has made a difference in even not only in cities, but going to rural areas where we have tried to really using the thermolytics device as a wonderful invention by you and your team. I want to really congratulate you, and you have become very prominent now all over the globe. Wherever I go, they talk about you and your invention, and very appreciative of the way you have gone about. And it's really wonderful that it's an Indian thing. We have done it, and we have got global recognition. You have, and congratulations. And as I, just to take you from what we have done in cancer today on this day, I just want to say that we all know, in my 48 years in oncology, from where we were 40 years ago, even in India, abroad, and even in India when we started our first Bangalore Institute of Oncology, which kind of matured to its HCG, tremendous progress has been done. And today, we are not only looking at how to prevent cancer, it's a lifestyle disease. There are ways to prevent. We are also looking at immense research in cancer. And one of the things we are doing is, we all know obesity is the #1 cause. Inflammation is the cause of cancer. And we want to attack it at that level. And HCG has been in the forefront of developing. Of course, we want ban nicotine, but that is not easy to ban. It itself will cause a decrease in cancer significantly. But we have developed alternate farming and various ways to see how we can, really avoid cancer itself. And in the US and all, if you look, the cancer incidence has actually come down because of all the measure. So healthcare measure, lifestyle are very important. While we are doing it, like what Niramai has done in early detection is equally important. We know particularly breast cancer is on the increase. I want to take a minute and talk about breast cancer. Some interesting data has come where we are getting involved in the pharmacotoxicity of this, where we are finding that the degraded products of herbicide pesticides are depositing in the breast adipose tissue. And we are trying to work with the CCAMP now to see whether we toxicology wise, based on the breast tissue we remove, can we identify not only in cancer patients, even in benign conditions, this toxic material. But we know in the past the dioxin we know causes cancer. Can we identify a similar, and can that be the cause of increasing incidence of breast cancer in women? And it could be a major breakthrough if in India itself we'll identify, and it could give us who are the people, and based on genomics, like we know BRCA2 and all causes possibly causative mutation for breast cancer. Can we tie that together and see how we can possibly bring down the use of herbicide, pesticide, more organic food? So this itself could actually decrease cancer. I'm firmly convinced of that, but we need evidence, obviously. So talking about evidence, in India, a lot of cancers are very prevalent. Head and neck cancer, now breast cancer, and a lot of reasons we know, but unfortunately, people come in various stages. But today, even lung cancer, I'm very happy to say that with available treatments, right treatment the first time, if given, and don't give a chance for cancer to recur, we can actually have convert cancer to a chronic disease. While we may not be able to prevent all kinds of cancer, but cancer can become chronic disease like diabetes. Today, somebody who has got diabetes, who is well managed, they can lead a normal life and die from other causes, not from diabetes. So that is what we are hoping. Even in cancer, we can achieve. Not only through early detection, but through some of the means where even recurrent disease advance we can do. And HCG is not only a service provider, but we are very deep into genomics research publications. We have done one of the largest genomic accumulation of high-end genes, and found out that why in Indian genes it may be different compared to the Caucasian. And recently we found out African genomics is different. And we have had some case studies where it has never been reported in the world, what we call as tumor mutation burden. So very interesting growth. And metastatic disease of lung, people are living for a long time. So essentially, what I'm trying to convey is while we still are fearful of cancer, going forward, I think we have made long strides in the last few decades where cancer patient can definitely live a normal life. So HCG believes today in not using certain terminologies like palliative care, your stage 4, your terminal. We don't use it for diabetes or blood pressure or asthma. Why should we use now? Because people are doing better. And even the term cancer survivors, cancer victims, we should eliminate. We should use the name of the patient. We should say Miss Padmanabhan, Mr. So-and-so, rather than Mrs. Lakshmi, rather than saying the patient is a cancer victim, cancer survivor. So that itself changes, because when you hear people talk, I heard the president of US, former president, once talk, this is cancer of the society. See, when you use terminologies, it gives a negative connotation to the whole public. Cancer means dreadful. So I think we should influence the people not to use such language. And cancer should be very specific for certain things. So we see the positive side of the cancer where it is conquerable, where people will do well. And today we don't fear diabetes, so why should we fear cancer? That is how we should move forward. And also we should discourage one of the statements, a lot of people may not agree, is to discourage setting up palliative care centers. See, that itself has a different connotation as though we can't control pain. I'll just give you an example. My clinic is advanced and recurrent tumor. Just few weeks back, patient came in a stretcher with lot of pain. A lot of pain, and people had put them on morphine. They said no hope, they'd done everything. But when we analyzed on the genomics and all, because we specialize in that, we found out there is a certain genomic where certain drug like lenvatinib actually can work in a colon cancer. When we put the patient on that, last Tuesday I saw the patient, she walked in completely pain-free. What was considered terminal is not, and she can live for next several years. So all I am saying is the terminology we use sends a message. Imagine a patient where we tell you are stage 4. I am going to give you palliative care. The patient will say, anyway, I am on my way to the grave. Why I want treatment? So we have to avoid such thing. And we have to be, as doctors, as healthcare providers, whether nurses, paramedical staff, terminology conveying that body language to the patients matters a lot. So we have to convey it in a way which is more practical today. First time right treatment, and finances are important in India. How do we create a model, financial model, crowdfunding, other models, so we don't deny treatment? And one of the models we have created, which has been a major Harvard Business School study for us, is how do we treat every patient and cross-subsidy? We have to cross-subsidy. If a patient needs treatment at 11 o'clock in the night free of care, why not a radiation? So that model, we have to take it forward. And I hope with these new innovations, technology is going to play an important role. Mixed reality, tumor boards, virtual tumor boards. What was taking weeks together in a matter of minutes, I can bring in experts to give advice to the patient in matter of minutes. I can have the radiology, PET scan imaging, I can have the screening imaging, I can have everything and tell the patient, this is what our team, whole team recommend. That is what we are doing today. And it was thought to be unthinkable. So the technology has leapfrogged us, India. I'm very happy to report because of this and that data we are doing, breast cancer, our data shows we are equal to the best of centers in the world. So as doctors, we are very good. As scientists, we are very good. When we can run major companies abroad like Microsoft, Adobe, Google, to name a few, MasterCard, we are bright. We are intelligent. Even doctors abroad run major institutions. When we go abroad to meet doctors, a lot of pain, they meet only Indian doctors. So we are a damn capable people. Our IQ is very high. You see, Geeta, what is our IQ, Geeta? Huge IQ. When we see people like you, scientists like you, we have to get confidence in ourselves, in our own country. And that is important. And I think we can do trials, and we lack in research. We can do a lot of research trials, and particularly head and neck cancer. We have volumes. We can show to the world we are leaders. We are today followers. We always quote, so and so MD Anderson did, Sloan Kettering did. Why not our own Indian hospitals? Why not our own self? Quote, and they can follow, create protocols for our own thing, and be a leader in this field rather than the follower. And when we have the infrastructure today, we have the phenomenal technology, inventions like what Niramai has done. Kudos to all of you. And we have to be leaders. We have to strive for that. And one message I want to say, World Cancer Day, for our Indian public: stop being followers. Start becoming leaders. And with this, we can win the war on cancer. I wish you all the best, and for this day and future. Every day is a World Cancer Day. That is how we have to go on and develop this. And all the best for today's program. Geeta and the whole group, thank you very much for having me.
Thank you. Thank you so much for your kind words. And honestly, yes, we should be the leaders and, pave the way. Absolutely, sir. Thank you. Thank you so much for your inspiring words. And thank you very much for sparing the time to address us. Thank you. Thank you so much, Dr. Ajit, sir. Thank you. Thank you very much. Moving on to the next expert, we have Dr. Sandeep Naik, sir, who has joined us, just making you co-host. And I request Dr. Charita to introduce Dr. Sandeep Naik and talk about him. Yeah, go ahead. Dr. Charita is a senior clinical researcher of Niramind. Welcome, Dr. Sandeep Naik, sir.
Thank you. Good morning.
Good morning, sir. Go ahead, Charita.
Thank you, Dr. Geeta, for the opportunity. It is my privilege to welcome Dr. Sandeep Naik, who is a leading surgical oncologist. He is the founder and chief of Surgical Oncology Max Clinic. He is the director of surgical oncology, professor and HOD, and his expertise is in minimal access surgical oncology, and he is the director at Fortis Cancer Institute. His major areas of interest include colorectal cancer, head and neck cancer, breast cancer, urinary tract cancer, etc. After pursuing MBBS from Kasturba Medical College, Dr. Naik did his post-graduation in general surgery from Government Medical College, Calicut. He followed it up with a doctoral in surgical oncology from Chittaranjan National Cancer Institute, Kolkata. Then he went on to acquire his fellowship in laparoscopic and robotic oncosurgery, Edinburgh, UK. He is a member of various prestigious associations, including Royal College of Surgeons, Edinburgh, UK. Over the course of his career, Dr. Naik has treated thousands of patients, not only from India, but all over the world. He has performed many innovative and award-winning surgeries like Niramind for oral cancer and robotic-assisted bilateral axilloinsufflate thyroidectomy, shortly called as RABBIT. This is an alternative to open surgery for thyroid cancer. So it is our privilege to listen to you, sir. Over to you, sir.
Thank you very much for agreeing to address us. I urge the audience to really make use of this half an hour that we're going to get with Dr. Naik, sir. And over to you. Thank you so much. We really look forward to your talk, sir.
Thank you, Dr. Charita and Dr. Geeta. So it's my pleasure to be here, and thanks for organizing this session, because as World Cancer Day, we are looking at various aspects of cancer, and based on the theme, we are talking about it. And there are many things which are happening, but anything we do today is meant to, to bridge that gap which exists in the cancer care around us, be it in India, be it in all over the world. So the whole theme is about bridging that gap and making overall outcomes for the cancer patients better. Now, I'll be talking about two cancers, oral cancer and breast cancer. And first of all, when I was asked, what I would like to talk, I chose these two. And the reason was this. If you see this graph, you will see among men, the most common cancer is oral cancer. And among women, the most common cancer is breast cancer. So if you see this, this is the reason why these two cancers become extremely important when it comes to preventive strategies and the outcomes are concerned. So, and also remember that cancer incidence is increasing over time. It's been constantly increasing. This is just 2004 to 2020. The graph is uphill. So when this change and at present, we might say it is the second or third most common cause of death in the population. But very soon, it is expected to be the top cause of death. So can we change things? Can we make it better for our people is what is the concept which we are looking at. Now, what is the Indian scenario? We'll look at the Indian scenario for both breast cancer and oral cancer, and we'll see what would be the best solution that we have. Now, for oral cancer, as you all must be knowing already, that it's most common cancer among Indian men, and it is tobacco related. More than 70% of oral cancers are related to tobacco, any form of tobacco, let it be smoking or chewing tobacco. Any form of tobacco is associated with oral cancer. So it is 70%. which means if tobacco consumption stops, 70% of oral cancers will be eliminated. So, but also remember there are this 30% is also very significant, and it is not associated with tobacco. So it's not that we can ignore if tobacco goes. So the other problem of oral cancer, especially when it is delayed in diagnosis, is the disfigurement which it causes and the functional issues related to the treatment, because it's functional issues means, ability to eat normal food, ability to go out in the public. In fact, there are a lot of social issues because of the treatment itself, because patients may have some flap reconstructions which will make them look different from others. So these issues can become a problem for a given patient, and all these things can be avoided when the diagnosis happens early. Now, looking at the age group which is most commonly affected as far as oral cancer is concerned, in India, as of now, what we are seeing is a peak around the age of 50s, 55, late 50s. This is when oral cancer happens. And of course, there is again a peak at the later part of their life in their late 60s and 70s. So it is a disease of old age like all other cancers. What is important again? What is the gap that we are seeing in this cancer? Look at this. Only 25% of the cancers, oral cancers, which includes part of head and neck cancers, are diagnosed early enough. Most of these cancers are picked up in the late stage, that is in locally advanced stage where lymph nodes are positive and all that. And forget, this is the problem. This population, when diagnosis happens in a locally advanced disease, the outcomes are not as good as early disease. Not only the cancer related outcome, we are talking about social outcome, the outcome of appearance and all that. So this is a big concern when it comes to treatment, and this is a gap which we can easily cover because it's not a very difficult gap to cover. Now, what is the Indian breast cancer scenario? In our training periods and when we were younger, what was taught to us was that cervical cancer is the most common cancer in India. But over the years, the scenario has completely changed. Today, breast cancer is the most common cancer, and the cancer scenario also has changed. So ovarian cancer has also become third most common from the 6th. So there is a change in the pattern of cancers. This is only about women. This is a change which has been seen initially in the urban women, and now the same thing is being reflected in the rural women, rural population as well. So this is a constant change. Things keep changing. So this is also not permanent. This is also going to change with the advancements in technology, the mindset, and all that. But what is very concerning for us, again, a big care gap that exists in our society is even today, about 60% of our breast cancers come in stage 3 and more. In fact, if we include stage 4, it is quite a lot. In fact, 70% of our cancers are stage 3 and more. It's quite bad. It's only about 30% which reaches us in early stage. This is a huge gap which needs to be covered. And this is the scenario. What is also peculiar in India, which is not there in other parts of the world, is we have a peak in the late 30s, and then again one more peak in around 50 years of age. Means the majority of population get breast cancer around this time, around 50s. And some of them get little earlier. We see this very, very commonly in our practice. We see a lot of patients in 30s, 35 getting breast cancer, and then another peak after 50. So this is the scenario. But when you compare it to the worldwide population or Caucasian population or Western world, their peak is little later. They get around 60s. So Indians get breast cancer earlier than the Western counterparts. So that is a concern. We need to be aware of this, and we need to address this issue as well. How do you bridge this gap? So, this gap can only be bridged by overall awareness. So awareness is about two aspects of it. One is to reduce the risk, what is called as primary prevention. And the other side of it is what is called as secondary prevention, where we detect early enough so that the damage caused is less. So these are the two ways we can have an awareness, overall awareness of the situation. Now, how do we prevent? This is a simple nomogram, or not a nomogram, sorry, a graph which can tell you how to reduce the risk of cancer. The most commonly known things are there in this. Healthy weight, physical activity, maybe 30 minutes of walking per day, eat healthy diet. Then comes what is not to be done. That is all the, fast foods, processed food, junk food, the sugary drinks have to be avoided, red meat, especially sausages and all that, to be avoided. Limit alcohol use. Absolute say no to tobacco. That is very important. I have already told you earlier. Do not use any supplements. They do not help in any way. So these are the things. And of course, we all know that breastfeeding among women reduces the risk of breast cancer. And a close follow-up in the long term after your diagnosed cancer is very important, because if you don't follow up and you develop a cancer recurrence, you may miss an opportunity to get a cure. So these are the most important things which are preventive or prevention recommendation. It's from World Cancer Research Fund. It's a very good comprehensive thing. Now, what is another thing which is important for breast and oral cancer is self-examination, because these are two areas which are easily accessible. They're not like, hidden areas of the body. They're easily accessible, and a good sense of awareness can actually prevent most of the deaths in these two areas. Now, oral self-examination includes standing in front of the mirror and looking at all the areas of your mouth, A, B, C, D, E, F, 6 areas. If you look at them, if you know what is, any new thing which is there, any white patch, anything, any nodule, any ulcer, any patches, any lumps in the mouth, new, which you're not seen last month, any self-examination, generally we say do it once in a month, not every day. So if you have seen last month, first of a month, next month when you see first, if you see any difference, any new thing, that needs to be evaluated. So that is the basic premise of doing self-examination. Now, see, these are the things which are looking for. Any patches like this, any lines like this, whitish, new change in color, any reddish patch. These are reddish patches. There are some nodules. There is a whitish patch over here, white patch on the tongue. There is a red patch. So these are the things which are looking at. Anything like this, any news thing which is appearing needs to be reported and investigated. Now, coming to, remember I told you already, people who consume tobacco and alcohol are at a higher risk of oral cancer. They need to do it strictly every month and see for any new changes. And now it's not only just them, it is for all others, but important that they see, because their risk is much higher. Now, our idea is to diagnose oral cancer when it is like this, or before cancer, pre-cancerous. It's quite easy to diagnose, just an awareness is required. And we don't want to diagnose a cancer like this, because the morbidity and outcomes are much worse. Now, coming to breast examination, breast self-examination, again, in Indian scenario, I feel it is very important, though there are many countries with many research which has said it is of less use, but we are not actively using mammography or any other form of screening techniques very extensively. So when it comes to it, we need to continue with self-examination so that the breast lumps which are missed otherwise should be picked up. So this involves three steps: inspection of the breast in front of mirror, lying down position, feeling for the breast, and standing up position, feeling for the breast. So these are the three steps, clear steps of breast self-examination. This is a short video which shows how to examine. This is downloaded. I found it quite simple and interesting. So I found that, it's worth showing it, how to do it. Stand in front of the mirror, look for any changes, any dimpling, this one, fix a date. If you are menopausal, you can just look at any fixed day, otherwise day of the month, 14 days from your menstrual, or one week from your menstrual period. Compare with the previous. They're recommending taking a picture. That's an optional thing, but stand in front of the mirror, look at yourself and see for any changes, look for any dimpling, look for any redness, any puckering of skin, any bulges or lumps, any rashes, swelling of breast, overall swelling, any discharge coming from nipple, especially any blood in that, any change in the position of nipple. Raise your arm, look for any changes in the breast, and do the same with your hands down, bending forward, all those, any changes, and look for any changes in lying down position with the palm of your hand. You have to check with the hand surface, not the tip of the fingers, so that any new changes, anything can be felt. The motion has to be circular, and all the areas of the breast need to be covered when performing this test. And once that is done, another way to examine yourself standing up is to look at yourself or feel the breast during taking a bath or shower. So by this, any lump that is felt can be evaluated further with mammography and clinical examination, and then further investigation is possible. What is mammography? In fact, mammography is an X-ray form of assessment, and usually the breast is compressed and X-ray is taken in two angles. And usually additional ultrasound is required to assess for any changes, any factors which have been noted during mammography. So this is an X-ray. This is how any small defects in the breast are picked up by mammography. And the major issue with mammography is the reach, because it requires a lot of it's an X-ray. It requires to go to periphery when evaluation has to be done. It's a technology-driven, manpower-driven thing, which has its own hassles, and it's a very costly affair to really implement and do, and requires a good assessment by a radiologist. You need a radiologist to pick up any lesion. So manpower intensive for that reason. Now, other one which Niramai has utilized and used an AI to do is thermalytics. In fact, this is a promising device wherein changes in the temperature of breast are assessed in order to determine if there is a possibility of a problem. This is not diagnostic test, but it can pick up a suspicious area easily, and it can pick up those people who need further assessment. It does not mean that the person who has been picked up by Niramai has cancer. The Niramai device is actually picking up those patients who need further evaluation. So it's not a diagnostic tool. It is a tool to find out who need further evaluation. That is the purpose of screening. Screening does not mean that it is diagnostic. So, people should not get panicked if a report says that, you need further assessment. It only means that, you have some things which require further assessment, which require further testing. It may be ultrasound, it may be mammography, it may be a biopsy. So further assessment is required. So basically it forms as a filter before further evaluation of a person. So that is the whole concept of this. What is recommended as of today? recommendations are that 20 years and above, you need to do regular breast examination, and if any symptoms or any signs are noted, you have to go to a doctor. If you are 29 to 40, 39 years, breast examination plus doctor's clinical examination every 3 years, and if you are above 40 years of age, breast self-examination plus doctor's examination plus regular mammography once every 1 year or 2 years is what is recommended in India at present. Again, coming to the advantage of thermolytics over this mammogram is that it is non-radiation. There's no radiation, so it can be used easily. So these are some of the advantages, and it does not require any contact. There's no compression of breast. There's no pain involved. So these are the advantages. So, but it's a new technology in the arena compared to mammography. Only time will tell how it will stand. So coming to, if you want to read more about cancer prevention and all that, I just got finishing my second edition of my cancer prevention booklet, which will be released maybe in few days now. So it is downloadable. It's a free book, which it's a second edition. So coming to my last slide, it is the just to mention. Am I audible?
Slightly breaking up now, sir.
No, I'm using a dongle. That's why. Now it should be. I saw that the internet is unstable.
Yes. Okay.
So my last slide about Cancer Day. I already spoke about this. We are talking about closing the care gap. What is important in this is these are few points which I want to make. Cancer does not mean the end. It is just a chronic disease today. There are many things which are available. Cancer is curable in most of the patients. And in those whom we cannot cure, the idea is to make it into a chronic disease. There are many things which are available today. There is something called comprehensive genomic profiling, and there are many things which are available which try to make a cancer a chronic disease, even a stage 4 cancer. But most of the other diseases, up to stage 3, our attempt is to cure the cancer. We are not looking at making it a chronic disease. A third of cancer can be prevented by lifestyle changes. I showed you the graph or the diagram for that. Cancer is a painless disease. I always point out this because people think cancer means pain. Painless lump is more important than a painful lump. Cancer can be treated successfully when detected early. Very important. This is the importance of screening. And there are many, many tools available today for cancer screening, which can detect it early and make you one of the people who is cured of cancer. Thank you very much.
Sorry, I was muted. Thank you very much for that wonderful, summary and guidance on early detection, Dr. Sandeep, sir. Any questions from the audience, please put it on the chat. I have a burning question after I heard your detailed, introduction from Dr. Charita. What is this rabbit, sir? Please, can you explain to our audience in a easy way for us to understand? Meanwhile, please share your questions.
See, I believe, every surgeon or every cancer specialist is a researcher. So, and you have to constantly think how to make a cancer care better. So, these are some of the surgical techniques which I have invented. One is rabbit, which is for thyroidectomy, because thyroid diseases and thyroid cancers and thyroid nodules are very common, benign or malignant. So rabbit is a technique of doing it robotically. Initially, I started it as a scarless technique. There are other techniques also for robotic thyroidectomy, which involves large wounds in the back of the neck or in the armpit. But this technique involves very, very small wounds, very tiny wounds with which we can do full surgery in the neck and come out. And initially we started it as a scarless surgery, but then over time I realized that it is very advantageous for the patients, in the sense we have a lot of magnification. We can save the recurrent laryngeal nerve and the parathyroid glands and all much better. So the overall outcome is better than open surgery when it comes to robotic surgery. So nowadays I'm not offering it just for scar. Scar is the least of my list. In the list, I talk about the advantages of why it can be done. And most of the patients, when they come to me, they come for robotic thyroid surgery.
Yes.
Rabbit, they would have known when they come to me. So it's not that, but I have to explain why what are the advantages. Other than that, other thing which recently got me an international award was the Riamine technique for neck dissection for oral cancer, which is actually for oral and head and neck cancers, especially where we have to do lymph node dissection of the neck. Okay. So generally it is done with a big wound in the neck like this. But when I started this again a technique which I developed over the years. Again, same reason, to reduce the scar, but the advantage is the precision of robotics and the kind of dissection which happens, the magnification and all that. So it has now become a standard of care in my setup that most of the patients, whenever they come, we offer robotic for neck dissection whenever it's feasible. So these are some of the things.
Will be less, the recurrence will be less because of the precise
recurrence. We don't know, but what we see is the lymph node yield and all that is good, and we can see the quality of work which we do is far better. Recovery is much faster. These are the things. See, many things require years of looking at the data to really tell whether it is different or not. So sure. That's how it is.
Perfect. There are a few questions from the audience. Charita, you want to take it quickly? Maybe we can take 2 questions from here. Okay, so there is one question from Dr. Manjula. It says, is pollution cause for cancer?
Pollution does cause cancer. There are, see, for example, lung cancer. It's one of the factors. About 20% of lung cancers are caused by pollution. Thyroid cancer is because of other pollutant, that is radon. Radon can cause lung cancer also. So air pollutant it is. So environmental pollutions are known to cause cancer, skin cancers in some extent. There are many other cancers which may have, like for example, pollution, pesticide pollution can cause. Is not proven yet, but there are some evidence that there is some accumulation. Accumulation alone does not mean that it is a cause. Accumulation can happen. So we don't know, but there may be some factors which are involved. But proven things are this lung cancer and the related to UV radiation and all those things, that cancers are there definitely.
Okay.
What are the main reasons for non-tobacco related cancers? Does passive smoking is included in tobacco related cancer?
Yes, passive smoking is one of the factors in cancer causation. But remember one thing. See, when we talk about cancer prevention, we are talking about what is preventable. But one of the most important unavoidable cause of cancer is age itself. So as you get older, your risk of cancer increases. Just like diabetes, BP, heart disease. So your risk of getting these diseases, Alzheimer's disease, all these things increase as you get older. So the most important unavoidable risk factor for cancer is age. Okay, so that kept us apart. We are talking about avoidable risk factors, and whatever we have spoken about till now is about avoidable risk factors.
Yes.
One
Okay.
more question. Can I take it, sir, please?
Yeah.
Why there are two peaks in cancer? Relating to that, there is one more question. Why is the breast cancer occurrence in the age 60 and above in Western population, but whereas it is 40 and 50s in Indian women?
We don't know. Unfortunately, we don't know. Actually, something which we need to study. In fact, there are many cancer patterns in India which are different from the Western world, and we don't know why it is so. Actually, something which we need to really work on and do research on, because you see, our cancer behavior is different from the Western population or any other population for that matter. So we need to see why, but as of now, we don't have a perfect answer for this.
So how often genomics helpful in screening?
I think this is the last question we have to move.
Yes. So
Genomics helpful in screening as of now. I don't know if the question is about, screening by blood test, genomics using, blood test. Actually, there is a lot of research happening on liquid biopsy like tests. Means, just take out some blood or some saliva and see the genetic changes in that, and see whether any DNAs are there, circulating DNAs in that, which can be used for diagnosing cancer or early detection of cancer. It's a worldwide research. Many studies are going on, and if that picks up, then it may be possible to diagnose cancer or screen cancer and pick up cancers without doing any of these other tests. We just do a blood test and we pick up that there is something, and then evaluate based on what results come. But we don't know when such results will come, when such tests will be approved, because it takes a lot of time from the ideation to results to implementation to making it an available, publicly available test. There is a lot of gap.
Absolutely, sir.
Mm-hmm.
So, I mean, we can go on and on. This has been excellent, Dr. Sandeep Naik, sir. Thank you so much for taking the time out. And I know you're extremely busy both at your clinic and the hospital. So really, really huge, thanks from our side for educating us on this. And congratulations on the new inventions that you yourself have made. And look forward to working with you in different forms as we move on and fight cancer and support the extremely huge expertise that we have in India, and research and clinical and tech, and then bring them all together. Maybe a blood test for all cancers and imaging test for all cancers. I think there's a burning question from Uma. Okay, last question. We have the next speaker also available. Only one question, Uma, please. Go ahead. You are on mute.
Yeah, I am. Thank you very much. First of all, from a great fighter and a thriver, or what we call ourselves, we don't call survivors ourselves. Thank to God again. I mean, 24 years now finished, and I just came back from SCG Bio Hospital walkathon and all that. So it was lovely. So I just want to, at least among my friends, doctor, in India, maybe it is because we always seem to get, even in late 70s and 80s, it makes me feel quite upsetting, at that age, why do they get breast cancer? They would have probably finished feeding the kids, because at that time, even my mother had 8 kids. So it was 1 dozen, cricket team and football team were very famous. But still, all people are getting it. And they're at home, right? At that time, they don't go. So it's not an environmental cause. I don't know what it is. So as you just now explained, maybe, I don't know, it is a food intake or the environmental issues. So that was one thing. And second thing is, what is the gold standard now, doctor, for mammo?
Right. See, for your first part of the question, the age itself is the cause of cancer in most of the people. So as you get older, the risk of cancer increases. There's nothing unusual about getting cancers after you're older. So that is age itself. Like, a old vehicle gets spoiled. Yeah, we are all vehicle anyway. So it gets spoiled, and that is a nature of, it's a nature's way. So you can't help it. So repairs do come. Now, when it comes to, you're asking me about gold standard as of now remains to be mammography as far as screening is concerned. That has not changed because, gold standard, when we talk about, it's always about what the textbooks talk about. So it has to be there. So, but I think, what Geeta has done and all these things might pick up and over time may become gold standard. See, what has happened over the last few years is AI is creeping into screening for let it be assessment of mammography itself, even X-rays and many other things, even pathology testing, because AI can assess multiple things and give us results. So the possibility of using, time today, I think we are in a situation wherein we cannot be dependent on one technology. We should be having multiple technologies catering to the same need, because a single question can be answered multiple ways. And I think we should have the willingness to accept that there can be multiple answers for the same question. So that is a problem. In fact, we need to look at that actively when it comes to, taking or telling that, this is the gold standard and nothing else will accept. So we need to accept multiple answers. Each test has its own way of answering it. So I think, thank you very much for having me. I think I need to go also. I had to do my OPDs. I'm a little behind schedule. Okay.
Yes. Thank you. Thank you so
Thank
much
you.
once
Thanks for
again.
having me.
It's been
Bye-bye.
a real privilege to have you as a part of the speaking panel. Thank you so much, sir. Thank you so much. Thank you. So next we have Dr. Madhu from Kidwai, who is going to help us understand more about interventional radiology. Thank you very much for agreeing to be part of this expert panel and educating us, Dr. Madhu sir. And I request Dr. Charita to sort of give an introduction to Dr. Madhu and explain to the audience about the expertise that Dr. Madhu brings to the table. And again, encourage all the audience to post their questions on the chat and make use of the excellent knowledge which is going to be shared now. Charita, please introduce Dr. Madhu.
Dr. Madhu is Professor, HOD, and Chief Interventional Radiologist at Kidwai Memorial Institute of Oncology. His interest especially is in oncoradiology, with a special interest in onco-interventional radiology. He has organized several academic activities, including CIRCON State Chapter Interventional Radiology Conference. He has been an invited speaker, presented many papers in national and international conferences. He is also a member for various organizations, including IRIA, Bangalore Oncology Group, Indian Society for Vascular and Interventional Radiology. We are happy to listen to you, sir. It's our privilege.
Absolutely. So we have a naive audience. Please educate us and maybe also define interventional radiology to many of us as well. Thank you so much. We look forward to your talks.
Thank you, ma'am. Thank you for the introduction and thank you for having me here. Am I audible?
Yes, sir.
And my screen is visible?
Yes. Maybe you can put it in the slideshow mode. Otherwise, it's fine.
Yeah, it is. Now it is visible?
Not in the slideshow mode. So it's only we are seeing the first one. The slideshow.
Just a second. Now it's visible?
Maybe you have to put resume slideshow. Are you using two windows, sir? There, two displays.
Just a second.
Just maybe Maybe it's going to a different display.
Okay, I'll just check on this. Now it is visible, ma'am?
No, actually, it is visible. The first one is visible, not in the slideshow mode. That's it.
Slides
So,
are moving? Are the
Slides are
slides
moving. Okay, we can continue with this only.
Yeah,
But if possible, you can give F5 or something. That's it. Function if
I'll continue with this. I think interventional radiology is not known to the common people as such. It is upcoming branch. It is there from the last few decades, but not many interventional radiologists were available to take this forward. Now I think we have plenty of interventional radiologists coming up, and every hospital started having an intervention radiologist in-house. So we can do many intervention cases. Basically, let me explain what exactly is this intervention radiology is. In intervention radiology, just like in intervention cardiology, how the cardiologist with a small hole, either in the wrist or in the thigh region, they're going to put a catheter and take it to the heart, and there they release the block or put a stent. So this is very minimally invasive but very effective. So the same thing we are going to do it in cancer patients. In so many cases now, the things have changed from only surgery to surgery plus. So in that surgery plus, we are there. So what we do first, in the simplest of the intervention radiology is doing FNAC to take a material. If this intervention radiology is not available means the surgeon has to cut open and take the tissue. That itself becomes a major procedure, and patient has to stay in the hospital for a few days at least, and a lot of morbidity also, pain related to surgery and all those things, anesthesia and all those things. But here we can put a small needle just like a needle size of an injection. Put a small needle, take out the material, give it to the pathologist, they will assess it. If they want a bigger chunk of material, we are going to do what is called as biopsy. So in that biopsy, we are going to put a bigger needle under local anesthesia again. It's a daycare procedure. We're going to put a local anesthesia into the region. So we're going to put a biopsy needle, take out some biopsies, at least 4 to 5 biopsies, and that will help in diagnosis. If this was not available, definitely cut open and take the tissue for biopsy. That would have been the alternative. Now we have moved from that cut open thing to a small whole biopsies, and this is quite effective also. In case of breast tumors, we also moved from regular biopsy to taking out the whole thing out. We call it as a VAB, vacuum assisted biopsy. In that, what we do, if the lesion is less than 2 centimeters, so we are going to put quite a bigger needle and take out the whole tumor out without a surgery, not even a scar. There won't be any scar on the breast tissue also. So these are the advances what we have in intervention radiology. Going forward, I'll show a few cases and I also explain what is the role of intervention radiology in cancer treatment. So this is the list of treatment, what we can really do and what we are doing in Kidwai Cancer Institute. So even though we are in a government sector, we are not far behind any corporate sector. What is available in the corporate sector, it is available in Kidwai Cancer Institute. And I'm proud to say that ours is the only institute, government institute in southern India, including all the 4 states, who is providing all these facilities to the poor and needy patients. And these are all many of them are available at free of cost.
We are not able to see the list. Sorry to interrupt. We are not able to see the list. Maybe next slide.
Yeah, now you can able to see?
No, sir, there is some problem. We are still seeing the first slide.
Oh, is it now?
Now it is moving. Moving?
Moving?
Yeah,
Okay.
now we can see.
Yeah. Now, can we see this?
Yes, sir. Yes, sir. We can see.
Yeah. Okay. So these are the procedures we are doing. Many of these procedures are available at free of cost to the patient, especially Vajpayee patients, means BPL card patients, and others they are affordable at a very cheap price. So in a corporate sector, these procedures are available ranging from 60,000 to 12 lakh. And we are doing a few of them at free of cost and a few of them at a very marginal price, just a material cost price. And if this or get involved in any of the Ayushman Bharat schemes, I think we're going to do all these procedures free of cost to the BPL card holders. So these are the just to start with FNAC and biopsies, as I told you, these are to take out the materials from the body, to cancer cells from the body, and to assess it. That's the role of FNAC and biopsy. Drainage means suppose there is a abscess, the pus formation within the body, like liver or anywhere in the body. Instead of operating, what we do is we're going to put a pipe from outside under ultrasound guidance or CT guidance, and we take out all the pus without doing a major surgery. It is just a small keyhole procedure. Patient will be having this tube for a few days, and the whole pus can be drained out. Even if there is a cancer patient, usually develop either fluid in the lungs or in the abdomen because of the cancer cell itself. So even for those patients, we can put a catheter, we can put a tube and drain out all the fluid which is there, which is unnecessary fluid which is there within the body. Not only that, we can also do what is called as pleurodesis. Means if there is a cancer, lung cancer patient, and patient developing accumulation of the fluid within the lungs, we put this tube inside, and we'll drain out all the fluid. Once the fluid is out, to prevent future accumulation, we are going to put some specific powders into the cavity and close the cavity permanently, so that there won't be any future fluid accumulation. And coming to this percutaneous biliary drainage, I'll just show some cases and keep explaining so that the audience can understand what we are doing. So these tumors, which usually comes in the early childhood, maybe in the first 2 decades of life, these are called carotid body tumors and nasal angiofibromas. These are all blood-rich tumors, blood-rich masses, cancers. When the surgeon try to operate in these areas, this is there in the nasal cavity, and it has gone out of the nasal cavity also, So these tumors, while operating, they bleed like anything. If it start bleeding, the surgeon's attention will go towards preventing the bleeding rather than taking out the tumor itself. In that thing, he may completely not remove the tumor. So he may partially remove it and come out. So what we are going to do is, in such a case, we are going to enter from the thigh region, go all the way into the tumor, and identify the arteries, the blood which is supplying to the tumor, block it completely. When we block that artery completely, the surgeon can go in, can resect the tumor completely out without leaving behind any residue and without any blood loss. This case, if it is not this particular case, if it was operated without doing embolization, what I told you now, blocking the blood vessel, if they were doing this without that, then patient would have lost at least 2 liters of blood, and surgery won't be easy. But when we did this blocking of blood vessel, the embolization, pre-op embolization, what we call, there was no blood loss at all, and surgeon can go in deep and take out all the tumor what was there before, and complete the surgery was very successful and very, very minimal blood loss. After finishing the procedure, the surgeon was so happy, he immediately sent these images and called me. So surgery really went well.
Also, there's a real problem. Maybe stop sharing and sharing again, sir. Maybe.
Okay, I'll close this again.
Now we can see now.
I'll close it and I'll share it again in 1 second.
Yes, sorry about that. Maybe you can stop sharing. Yeah, stay.
Yeah, I'll just a second.
Yes. Because they are really good pictures, so to get an understanding.
Now able to see this?
Yes. Yeah, yes, this is good. This is good, sir. Yeah.
Okay, ma'am. Yeah. So this how
Yes,
we
in the
do.
procedure slides.
Yeah, this is the procedure slide. Here we can see this catheter. It has gone up to this blood vessel, which is supplying the tumor, and we have blocked it. After blocking it, so surgeon operated this, and the operation went really well, and he removed all the tumor without any blood loss. He was very happy. And also the patient get rid of this tumor. These tumors usually they are benign but very vascular. They bleed like hell, but they are benign in the sense they won't spread into the other parts of the body. Once it is completely taken off, they won't come back. Those kind of tumors of these. So completely removing is the prerequisite for a successful surgery in these cases. Once it is completely removed, these tumors won't come back again. These are called juvenile nasopharyngeal angiofibromas, carotid body tumors, which comes in the first 20 years of life in children's, basically, or in adults. So if we totally remove these tumors, it won't come back again. So to totally remove this tumor, we need to have a bloodless, less bleeding area. So to create that, we embolize. That's our role. So surgery plus what I told, this is our role. So another such case, which is again there behind the nasal cavity, this bright structure, what we are seeing is the tumor. This is the tumor here, which is almost going towards the brain. Remove. This is very small area where surgeons won't have much space to even manipulate. And if it start bleeding, it will be very difficult for him to stop the bleeding also. These cases we did embolization. This is how a tumor looks like. We completely embolized it, and means completely blocked the blood supply which is going to that particular tumor, and he could operate clearly, and there was no tissue left behind. So this is the cavity. You can see where he has operated and taken out. And if you see this cavity, the surgeon is having a very small space to maneuver his hands, very small space to do anything. Suppose if it bleeds, his attention will be more towards stopping the bleeding than removing the tumor itself. So this case also, there is hardly any blood loss, and tumor was completely removed. And if suppose if we have not done the pre-op embolization or blocking of the blood vessel, their plan was to cut open from the cheek side and reach the tumor. Here, what they did, they through the mouth, they did all these things. There was not even a single scar on the face. That's also very important from the patient point of view, because he's just an 18-year-old kid. And if any scar on his face, it will be there permanently. Even that was prevented with this. So our role was just to prevent the blood supply to that particular tumor, and it immensely helped the surgeon. Not only the surgeon, even the patient. He didn't have any scar, and he's completely get rid of the tumor. So these are the tumor pieces. You can see if it is a completely, if it is more blood-rich tumor, it would have been very bright in color. Now this is pale in color because we have completely stopped the blood supply to this. That's our role. And coming to these bone tumors, few of the bone tumors, especially the benign one, this is one such bone tumor. There is a small tumor here. This one will cause a lot of pain. And to do the best way previously available was to remove this part of the bone. Just remove this part of the bone, patient will get rid of the tumor, and the pain will come down. But if you remove this, the bone will become unstable, one thing. Second thing is, it's a major surgery. So with intervention radiology, what we can do, put a needle like this and burn this. This is called radiofrequency ablation. We did exactly the same, and we went there. This was the place where the tumor was. We burnt it, and this is just a cure. You can see this. There is no scar at all over the skin. Patient can walk out of the room immediately. So that minimally invasive is the procedure. So another case. If you see this, this is the lesion. You can see compared to opposite side, there is a bright structure here with a block dot. This block dot is the tumor. That bright structure is the reaction of the bone. That's called sclerosis. So this is the tumor here. This is called osteoid It causes intense pain. For this kid, a 15-year-old, he was not even willing to go to college. The reason was he was limping because of the pain. And how to get rid of this? Operate and take out this particular thing. But that may cause instability in his bone, one thing, and limping may not be completely go off. The limping was mainly because of the pain. So rather than doing a surgery, we did radiofrequency ablation to this, put a needle there, burn that area, the procedure is over. And it hardly took us, say, 15-20 minutes. And patient just walked out of the room, and he didn't had any pain afterwards, and his limping also came down within just matter of 15 days. So next important role of intervention radiology is in liver tumors. So these liver tumors, if they are seen in the earlier stage, like stage 1 or 2, the surgeon can go in and take it out completely. That's the best possible treatment available. But unfortunately, 90% of these tumors are detected only in the late stage, where surgery has no role at all. Surgeon cannot go and take out the tumor at all. In such a scenario, the patient will land up either with us or with a medical oncologist, where they give only chemotherapy, means drugs, but they are also not effective. So what we do in such a case, just like cardiac angiogram, cardiac stenting, we'll puncture this thigh region here. And from here, we'll enter the aorta, that is a major blood vessel of the body. From there, we'll enter the blood vessel, which is supplying to the liver. Again, from there, particularly, we will enter the blood vessel, which is supplying the tumor here. Once we enter those tumor, we will put the chemotherapy agent into it and will block it. So instead of giving a chemotherapy to the whole body, here we are giving chemotherapy only to the tumor, only to the cancer mass. So the side effects because of the chemotherapy, which would have been otherwise there, will completely won't be there in this case. Very minimal symptoms. That is basically because we are going to block the blood vessel. That will create more pain than the chemotherapy itself. So here I'm just giving an example. This is the tumor here. In this case, you can see here there is a pipe here. There's a catheter. This is within the major blood vessel. From there, we have entered into the the liver blood vessel. From there into the tumor blood vessel. You can see that this is that mass, cancer mass. This is the cancer mass, and we are injecting chemotherapy drug and one material called Lipidol into this. And after that, we are going to block this blood vessel. So this is the end result. So the tumor is completely filled up here. You can see there is hardly any chemotherapy we have put into the rest of the liver. So through this tube into this the blood vessel, which is supplying blood to this tumor, we have put our chemotherapy agent. We have put our chemotherapy drug. So the chemotherapy is just instilled into only the tumor, not to anywhere else, even in the liver. So the chemotherapy side effects were very, very minimal. If any patients are there in the panel, they would have definitely known what is the side effects of chemotherapy drugs. Very toxic. And those toxicity can be prevented by just putting the chemotherapy into the cancer tumor itself. The response was very good in that. This is another case where you can see number of liver lesions. So this we did at least 4 to 5 different sessions, because we cannot control, we cannot treat all the tumors at one time. This is a neuroendocrine metastasis. The primary tumor was very small; it was operated, but the liver was showing multiple metastasis, means distant spread of the tumor. So we need how to correct this. The only way available previously was giving chemotherapy. That is again very toxic. But here, what we did the chemotherapy treatment only to the tumor through the blood vessel multiple times. These are a few examples showing the same. Multiple times we did it. So this is how it looks after putting a chemotherapy agent into it. So you can see these previously bright areas are becoming block areas. So the big tumors, we are completely treating them. There are few others also. These are all block areas represents the completely treated tumors. So this patient at least underwent 4 times the chemotherapy, this TACE procedure, and this person is really doing good. To completely cure the tumor, sometimes we mix up 2 to 3 procedures. This is one such example. Here, the patient, he was a singer from northern Karnataka, and he was also a teacher. So he was having one tumor sitting here. He went to a corporate hospital. They quoted something like 2.5 to 4 lakh for combining 2 procedures. So he came back to Kidwai. So this was one tumor, and one more tumor was there. For this, we did TACE, what is called as TACE, means through the catheter, we are installing chemotherapy agent into the tumor only. So we installed chemotherapy agent into the tumor. This is how it looks like. You can clearly see that it is completely filled with the chemotherapy agent now. After that, we did one more lesion was there, one more tumor was there here, and we did what is called as RFA. RFA means this needle will go inside. Just to say, this is just a needle. We are not opening it at all. Just a needle from the skin under the CT scan. We are putting into the tumor and we are burning it. So we burnt this tumor completely. And after that, you can see there is no visibility of the tumor at all. It is completely gone. So that effective the tumor ablation is. Another example, here you can see a bright area. This is the tumor. So under ultrasound, we burnt this area. This is that bright area. What you're seeing is the burning. This is the needle tip. So you can see this block area. Now the tumor is completely gone. This is complete response to the tumor. It is almost like doing a surgery. Instead of doing a surgery, if the tumor size is less than 3 centimeter and just less than 3 numbers, we can aramse do this procedure, which is a daycare procedure. Patient can come a day before, get the procedure done. Next day, patient can walk out. So unlike a liver surgery, which is very morbid, patient has to be in the hospital for at least say 15-20 days. If everything goes right. Otherwise, even the hospital stay may extend for months together. So this is just a 3-day procedure, and a very tiny small hole on the skin, nothing visible outside. Patient won't be having any morbidity, any issues at all. Just like radio frequency, that's called radio frequency ablation, and just like that, we have another modality, microwave ablation. This is also same method, putting a needle into the tumor and burning. This is one very interesting case. This fellow had a huge tumor on the right side. They operated it. These tumors, we cannot treat it. Surgeon has to operate on that. So now one kidney is not there. So you can see the MRI image. One kidney is not there. In the other kidney, he developed one tumor again. Now he cannot, the surgeon cannot operate this kidney also. If he operates this kidney, patient becomes like dialysis dependent lifelong. So he was referred for microwave ablation. So we did the microwave ablation. This is the needle through the skin we have passed. You can see this needle, and we completely burnt it. You can see this burnt area. So we completely burnt it. And after the surgery, the tumor was after the procedure, the tumor was completely gone. Again, he developed one more tumor. We did FNAC, and again we did RFA for that. We did just yesterday and one more radio frequency ablation for that. And so that's how in this patient you can see one kidney has been operated by the surgery. That's good. But another kidney is also having multiple tumors, at least 2 tumors. So one we completely ablated it, means burnt it. One more lesion was there. Yesterday we burnt it. Suppose if this modality was not available, then what will be his fate? So surgeon has to go in and operate. Either at least he has to take off of the kidney. So only 1/3 kidney will be left. That is not sufficient to maintain his body functions. Patient will become dialysis dependent lifelong. Otherwise, he had to go for a renal transplant. Now, we have taken out the tumor. We did this burning procedure like a radio frequency ablation and microwave twice on him. He is having a preserved kidney. He need not be dialysis dependent or need not have a transplant. That is the difference the intervention radiology is making with a small keyhole procedures. This is the proper keyhole procedures with a profound impact on patient lives. So we also do what is called as a TARE. TARE means radio embolization. We inject radio embolizing material into the tumors, just like what I explained in other slides, the TACE. The material is totally different, but it is very costly procedures. The few cases, I'll just to show in future slides, I'll show how the response was. Response is very significant, but the cost is also very high for these procedures. The cost was around 8 to 9 lakhs, I believe, but the response was also really great. Suppose we have also other roles like this case, whereas there is a large tumor sitting in the thorax. Surgeon has to operate on that, but it is having a lot of blood vessels, lot of blood supply. If once he go in and if there is a bleeding, it's very difficult for him to block the bleeding. So we did what is called as pre-op embolization. Before the surgery, we blocked the blood vessels which are supplying blood to that particular tumor, so that surgeon can easily go in and take out the old tumor without a blood loss. So this is our role. This patient also underwent surgery, and his surgery was successful. So venous stenting. Suppose if there is a tumor like this, it will block the blood vessels in this region, and the patient will develop facial swelling and upper limb, both hand swelling. He will sometimes even he cannot breathe. It will become it will complicate to that level. So in such a case, what we do, this is one such case where you can see a large mass. The main jugular vein which enters into the heart through SVC, superior vena cava, is completely blocked. He was having big facial swelling there. This is photo before the surgery. These limbs up, the hands were swollen, face was swollen. Is unable to sleep in a normal position because of all these things. So what we did is we put a stent across the superior vena cava, opening up the block. So once it was done, his blood started returning back to the heart from his face and hands, and his facial swelling started coming down. He was very comfortable after the procedure. This is another example how we do it. But without this, the patient has no alternative at all. So he has to live with the disease. With these minimal procedures, we're able to achieve a good result. Another thing is jaundice treatment. So if there is a tumor in the vicinity of the liver or in the pancreas or in the jaundice pipe ducts, that's called biliary ducts. If there is a tumor there, what it does, it is going to block this jaundice carrying tubes. They are called bile ducts. Once this is blocked, what will happen? The jaundice will spill over into the liver, from the liver into the blood. So jaundice level keep rising. At the same time, the liver functions start falling. Once the liver functions start falling, the bleeding parameters will get affected. So many things will get affected with the liver function abnormality. So what is the best way to do this? Either you come through the mouth into the stomach, and from there you put a stent. That is not possible always. Otherwise, what one need to do is put a needle from the skin in the upper abdomen into the liver, into these pipes, and put a catheter or put a stent. This is called PTBD, or biliary drainage. This is done for a jaundice which comes due to the blockage of these tubes by the cancers. So we relieve this jaundice. So one more important thing is, if liver function is not good, none of the chemotherapy can be given to patients, because all the chemotherapy agents will come out of the body through the liver only. Many of them, most of them, almost. So having a normal liver function is a prerequisite, is an important thing before starting a chemotherapy. So if there is a jaundice, they cannot be given chemotherapy. If there is no chemotherapy, tumor won't come down, cancer won't come down. That is the vicious cycle. So what we do, from the skin, we pass a needle through the needle will pass a wire into this system. Over the wire will put a stent and will release the obstruction. So this is how we are going to do. This is under X-ray guidance. We're putting a needle, putting a contrast, then putting a pipe there, and also putting a stent. So sometimes we need to put 2 stents like this, both the sides, right and left, so that complete drainage happens. So in this case, if you see, we have put 3 stents here. So this particular patient was a principal in one of the leading colleges of Bangalore. She came to us for the surgery, but surgery was not feasible. She underwent 3 stenting because the tumor was quite advanced. 1 stent, 1 stent, 1 stent. 3 stents are there. We put 3 stents here. We are quite aggressive. Patient wanted to get rid of this jaundice at any cost. Not only we did the stenting and released the jaundice, what we did is, through this stent, we gave the radiotherapy that is called intraluminal brachytherapy. So in coordination with our radiotherapy department, what we did is, through this stent, we left this particular probe, radiotherapy probe here, and we gave radiotherapy or the current to this place, and we burned the tumor. We can also do this with the radio frequency ablation, but that is a costly affair because this kind of bent tube was not cheaper, comes out cheaper, right? It is very costly tube. That's why we did radiotherapy. So we combined this procedure with the radiotherapy, not only relieving the jaundice, but also we are trying to cure the tumor here. If there is no surgery, there was no other treatment available, but now in Kidwai and also in TMH and few other centers, we started doing this intraluminal brachytherapy for these kind of tumors. So this patient is under follow-up. Probably we may see her after a month. We'll come to know what is her tumor status. So these are few such examples. When there is a urine blockage because of the cancer cervix, cervical cancer is the second most cancer in India right now after the breast cancer, and especially in the rural women, there is the most common cancer. This rural woman usually comes in the later stage. They won't even really reveal to their family members what's happening. That's because of the socioeconomic reasons. Once they come to the hospital, they'll come with either bleeding or with quite advanced disease, which is blocking both the kidney pipes, which will block the urine excretion, and it will increase the creatinine level, and renal function will come down. All those things will be there. For such a cases, we do what is called as percutaneous nephrostomy. Means we're going to put a catheter into the kidney itself to drain out the urine. That is one way. And second way is, from there we are going to put a catheter into the urinary bladder like this, so that the urine can come out through its normal course. So these are very small procedures, but very effective for the patient. These things will clear their renal function abnormalities. Suppose if there is a bleeder, you can see this is a big cancer sitting here. They operated it. Again, the cancer has come back. Not only that, it is affecting the blood vessels, and it has ballooned out the blood vessel. That is called pseudoaneurysm. So he was bleeding heavily from this particular tiny thing. This is called pseudoaneurysm. It is bleeding directly into his oral cavity. This is the oral cavity. This is the surgery they have done, and there is a tumor coming back here that is causing erosion in the blood vessel and causing bleeding. So how to control this? They put a patches here to control, but it was not able. They're not able to control. They try to open it and see where the bleeding is coming from. Due to pool of blood, they were not able to do that. So they referred the case to us. Again, from the thigh region, we entered through the blood vessel into this, and we put a coil. This is called coiling. So once we put a coil, there was no bleeding at all. The bleeding stopped. So that's how we are going to do. And this case, I think. So renal tumors, if there are any kidney tumors, and it cannot be easily operated, what we are going to do, we are going to block them by block the blood vessels supplying to that. So You can see here, this is the abnormal blood supply to the tumor. We have blocked it completely. There is no abnormal supply. So that's how we are going to help a surgeon to reduce the blood supply. Another thing is, if there is a liver tumor, if the surgeon wants to operate on the liver tumor, but the liver which we are going to leave is of not sufficient size, then what we do? We are going to do portal vein embolization. So in this case, this is the portal vein embolization what we have done. This means to say the tumor was there on the right side. The left lobe we are going to leave after the surgery, but that left lobe size was not sufficient. So what we do, we are going to block portal vein blood. There are two blood supply to liver, portal vein and hepatic artery. So we are going to completely block the portal vein, means blood supply to the right lobe, which is having a tumor, we are going to block it. This is how we have blocked it. Once we blocked it, the right lobe started coming down in its size because blood supply is not there. It start coming down its size, means becoming atrophy. And at the same time, the body is taking care by increasing the size of the left lobe. Left lobe will keep increasing in size. So that will be once the left lobe is increased sufficiently in its size, then the surgeon is going to operate and take out the right lobe. So the remaining left lobe with a good size is sufficient to maintain the body function. That's how we are going to do. And the next important thing nowadays, catching up with the common people, is the uterine artery embolization. This uterine artery embolization is usually done for the fibroids. If the woman is having a large fibroid and they don't want to undergo any surgery, then we can offer this uterine artery embolization, where just again a keyhole procedure where we go through the blood vessel and block those blood vessels which are supplying blood to these fibroids, so that the fibroid will come down in its size, and whatever the effect it is causing on the menstruation will come down. This uterine artery embolization is not only done for the fibroids, but also if there is a bleeding. Suppose after the delivery, you might have heard, after the delivery, patient died. One of the main reason in such a scenario is continuous bleeding. The bleeding won't stop at all after the delivery. In such a case, what we do, again, we'll go in. This is very emergency procedure. Once the bleeding, once the gynecologist sees that the bleeding is not stopped, they should call us immediately. So within matter of 10-20 minutes, we can get into the uterine artery and block both the uterine artery which are bleeding. And this is a life-saving procedure in such a scenario. So that's about uterine artery embolization. These are few images. We can see these pipes we are carrying within the blood vessels, and this is the blood supply into the fibroids. We embolize that. So these are those few pictures showing that. And I think this I'll skip. This is of not much importance. And suppose if there is a blockage in the blood supply of a liver, so we can do stenting. This is one such case where we have done a stenting, and the patient, because of this, just a small block, a patient liver got failed and he was having a large amount of ascites. All these things got relieved because of this placement of this stent, small stent. So these are the few intervention procedures which are quite effective, minimally invasive, but very effective. Only negative point I see with this is the cost. The cost is quite high. Maybe in corporate hospital it ranges from 1 lakh to 12 lakh. But we at Kidwai trying our best with the help of a donor to do all these procedures at very minimal cost or almost free of cost. And especially we are taking care that if the patient is not at all affordable, we are not sending the patient out. We are trying to get some donors for these kind of patients. And we are doing procedures even to a non-affordable patient who, even if he don't have a rupee, we don't mind. We will get donors on board, and we are doing these procedures. Previously, 5-6 years back, these procedures was like not at all affordable to a poor man. Now I think in Kidwai we are giving this this kind of service where even a patient with no money can have these high-end procedures. Thank you.
Thank you. Thank you very much, Dr. Madhu. I think this was hugely informative, and we learned a lot. I mean, I myself didn't know, what all interventional radiology can actually do. And I'm sure the audience likewise sort of have benefited a lot. And also to know the fact that these kind of procedures are available in our own Kidwai at, as you mentioned, at almost zero cost. I think it's a hugely, heartening thing. And thank you so much for the service you're all doing to the community. Otherwise, it's really, saving lives, literally. And as Uma is putting here, bless you. So nice. Thank you. Unfortunately, due to the time constraint, we are not able to go into the question answering, but this was hugely informative. And thank you very much, Dr. Madhu, for taking us through this and then enlightening us on what interventional radiology is and what are the different procedures that are really possible and what are those possible at close quarters like Kidwai as well. Thank you. Thank you so much, Dr. Madhu, for this.
Thank you, ma'am. Thank you.
Really appreciate your time during your very busy schedule as well. Thank you, sir.
Thank you. Thank you. Yeah.
Thank you. So thank you. And we move to the next speaker, Dr. Vijay, sir, who is online. And Dr. Vijay is going to speak about, one second. Yeah, we're going to put back that. How do we actually reduce the care gap in oral cancer? And I request Dr. Charita to give a formal introduction to Dr. Vijay. And thank you very much for agreeing to be a part of this session, Dr. Vijay, sir. And kindly share your slides. And Charita, please introduce.
Thank you, Dr. Geeta. Welcome, sir. Dr. Vijay Pillai is Consultant and Chief of Head and Neck Surgical Oncology at Narayana Health. He completed his MBBS from Kasturba Medical College, Manipal Academy of Higher Education. Further, he completed his MDS and fellowship in head and neck surgical oncology. His expertise include head and neck surgical oncology, including diseases of oral cavity, sinonasal complex, thyroid larynx, and hyperlarynx. His specialization is in head and neck reconstruction with special interest in microvascular surgery. He is also a member of various organizations, International Association of Oral Maxillofacial Surgeon, AOCMF. These are a few to list down. He has also several publications to his credit. Looking forward to listening to you, sir.
Yeah. Good morning, Dr. Manjunath. Good morning, Dr. Charita. Thank you very much for having me here. Just give me a moment. I think, I just need to share my screen. So I may just need to log out and come back in. Okay.
Okay. I think we lost Dr. Madhu. Is Dr. Madhu still there? He can take some questions. Yes, sir.
Can I share my screen?
Sure. Please share. You can hit on the green button, share screen. Yeah.
Is it visible, ma'am?
It's visible. If you can go to the presenter views.
So
Yeah.
Thank you very much. And, it was indeed an honor to be part of this portal on World Cancer Day. So the other day when Dr. Charita had called, with whom I have quite an old acquaintance, it was such a short notice. So I really didn't know what exactly to put across. So the topic I thought I'll just speak to you all, on the occasion of World Cancer Day was how can we reduce the gap in oral cancer care? And that's something which is quite close to us at Narayana Health, what we strive basically to achieve. So I'm sure, a lot of these things would overlap with the work that you all are doing in breast also. So I think, I'll just put it across over the next 15 to 20 minutes. I have no conflict of interest or disclosures to make here. And this is where I'm based at Majumdar Shaw Medical Center. That's part of the Health City campus. And the head and neck oncology, along with all the other specialties, serves for the whole oncology care from here. Now, as we all know, today happens to be World Cancer Day, and it's celebrated, globally on the 4th of February. And, the theme has been kept common for the past year, the coming and the future year, that is close the care gap. So it's basically been put across broadly from 2022 to 2024 that basically we need to close the care gap and everyone deserves access to cancer care. And what exactly are we looking at when, we close the care gap? It's first of all, we need to realize the problem. Of course, this year, what the theme is to unite our voices and take action. And of course, in the future year, we want to look at how we can challenge across the power authority so that we can basically execute what we are trying to achieve. Now, oral cancer is something which is very common for the subcontinent. And if basically we look at how oral cancer spreads, the problem is quite enormous. So if you just look at the data, the data which shows it across all the different subcontinents. So India basically shows almost about 80% of the cases. And if you look at it, the prevalence and the incidence of the cases are in stage 3 and 4. So it's basically stage 4, which is around 64.1%, and stage 3, which is about 28.2%. Now you contrast this with the European countries, and if you look at it with the Western, the American continents, you look at it, most of their cases are predominantly early stage. So unfortunately for the subcontinent, we see our patients at a very advanced stage. And this has a direct implication on how the outcomes of care are going to be. So this was one of the studies which was done in Tata Memorial, and they just looked at how the timeline in progression of disease happens. So if you look at the timeline in progression of disease, you have what is an early stage disease, wherein basically according to the AJCC staging, you put it as something which is a T1 or a T2 tumor based on the size. So it's roughly something which is less than 4 centimeters. It can be anywhere in the mouth. It can be on the tongue. It can be on the cheek. It can be on the gums. It can be on the lips. And the good thing here is that there are no nodes. So that is what is meant by N0. Now, it takes about a good 1 year for it to go to an advanced stage. That means where it either increases in size. So it moves from what is a T1 or a T2 to maybe a T3 or a T4. And from a disease which did not have any lymph nodes in the neck to something which is positive in the neck. In about 3 to 4 months, it goes on to something which is untreatable. That means it becomes something which is not going to be amenable to a form of curative treatment, either because surgery is completely precluded, or even the other modalities of treatment would not be effective if surgery cannot be offered. And we see a gradual decline wherein the patient's performance status and functioning declines, and it eventually results in death. So if you look at basically the timeline in progression of disease, the window of opportunity is basically somewhere around this 11.3 months. And I think when we say closing the care gap, we are looking at basically targeting it within this 11.3 months. So how do we do this? So there are multifacets to, basically trying to intervene and basically prevent this progression of disease. So if you look at it, it can be basically something which can be patient attributed, or it can be something which is professional attributed. So the first and foremost thing is the lack of awareness. With the lack of awareness and with increased amounts of denial, patients generally tend to neglect the earliest onset of symptoms. But the best cure is when you have got patients are seen at the initial symptoms. So consulting with a healthcare provider is generally not done, and it becomes only detected wherein there is a screening that is being done. So most of the times you're already delayed because of the patient attributed factors. This can be because, they would have either they would be busy with their family or with their work. So there would be denial of the fact that they would have been using the causative agents for oral cancer, or the very fact that they don't want to perceive that form that they may be actually having a disease which could be treated, and there could be a lot of psychosocial factors. Lack of awareness is something which I would not really agree with current knowledge, being so available across all the social media. where most of them would be definitely aware that tobacco would have the different significant deleterious effects in terms of cancer. So it's interpretation of symptoms which gets delayed. And if you look at it, the consultation with the healthcare professional would be the first point of contact wherein we can start the actual treatment. But you have something like about a 3.5-month delay, which again further retards the diagnosis and causes progression of disease. We would not say that it's only a patient delay. There is a definite delay in the time from which you have got initiation of treatment is started and to definitive treatment. So we cannot say that it is going to be only the patient who is causing the delay. There would be a professional delay also. There may be delay in the access to healthcare. There may be delay in diagnosis. There may be delay in misinterpreting the diagnosis. So all this basically comes to about 3 weeks. So by the time you have a definitive diagnosis and then the patient goes into surgery and definitely followed by any form of adjuvant treatment, you have got the total package or the total treatment time has got significantly delayed. So basically what we at Narayana are looking at is ways in which we can bridge this gap, ways in which we can make sure that the point of intervention where we have can actually not be retarded significantly, and we have scope for making sure that outcomes are definitely better. Now, there's a common thing, which I think everybody would know, that early stage disease has got better survival. It's almost around the order of 80%. As it goes advanced, it comes down. It comes down to the range of around 20 to 30. Why is this so? It's because the disease is no longer confined within the primary site. It has spread to the lymph nodes. The dissemination process to other parts of the body can be significantly higher. So the fundamental thing here would be with oral cancer, or for that matter with any form of cancer, is outcomes depend upon the stage and diagnosis of the disease. So the more advanced the stage, the poorer are going to be the outcomes. Now, if you look at the Globocan data, which says basically if you just focus on the subcontinent, you have the highest site, when you look at it among all the different sites of cancer in the body, still predominantly it's lip and oral cavity. The incidence across, of course, definitely in case of males is the highest here. Females, of course, it would still be breast cancer. But looking at the mortality, again, the mortality in males, the highest would be oral cancer. So oral cancer is something which is a definite killer. And that's something which we would definitely need to address, at least if you're looking at trying to bridge the care gap. Now, a few things just about, the background, understanding the etiology. I think, we all know it is related to tobacco. It can be related to smokeless tobacco. It can be related to betel quid chewing, betel leaf arecanut, alcohol, the conventional teaching of the 6 S's or the spices, the sharp tooth, sepsis, syphilis, that of course no longer stands there, HPV related. And of course, you have this unique group wherein there can be no habits. So the etiology is something which we need to spread more awareness among, because it's important that social media basically emphasize that these are the etiologic factors. These are the factors which can actually cause any person to have a risk of oral cancer. Do not neglect even any small ulcer or any red patch, which can be very innocuous and which can basically progress. The presentation can be varied. It can be just a white patch like the extreme left, which is, intermingled with a few red spots. It can be something which has got a very fiery red appearance, wherein, we call it as erythroplakia, which would harbor some form of malignancy. Or it can be something like a white patch or plaque. And this can also be something which may not be actually malignant, but it's important that we recognize the presentation. Now, if you look at the natural biology, oral cancer happens to be one cancer wherein, the disease has a natural course of progression. It goes from something which we call as potentially malignant. It moves on to something which has got dysplasia. So looking at how the scoring system for dysplasia comes in with the low grade and the high grade dysplasia, we are concerned with the high grade and the carcinoma in situ, because that is a point of intervention. It goes on to early stage, like I mentioned, and then of course into advanced stage. So the continuum of disease has been very well described, in literature about points of intervention, how habit cessation can actually bring the patient back to a baseline risk. there are certain points where intervention can actually reverse the deleterious effects of the carcinogenic agents. So realizing the problem, we need to look at how can we do early detection and screening? How do we spread awareness? How do we make sure that we have an early referral pathway? And of course, fundamental to all this would be to downstage the disease, because as I mentioned, when you downstage the disease, you have better outcomes, you have much more better cure. Now, awareness is something, which of course the government does, which a lot of social media does, which a lot of groups do, wherein they try to raise awareness about the deleterious effects of tobacco, the use of alcohol, awareness that you have any of the early warning signs, they should not be neglected. From a clinical point of view, what we do is we try to get in early detection and screening, try to establish a channel of care wherein you have got early referral, and all this basically looking at a point that we could probably downstage the disease. So when we celebrate World Cancer Day and we say, what is this gap? We are looking at basically two important things. Are we able to basically bridge the socioeconomic gap, and are we able to bridge the tenets of treatment? Now, the socioeconomic gap is something because oral cancer is not something which would afflict the very affluent. I wouldn't say that it wouldn't, but it's much more a commoner's disease, because that's the one population group who would be using tobacco habitually, unaware of the deleterious effects which have cumulative toxicity and result in carcinogenesis. So it requires a multidisciplinary approach. It requires a support from an institution which has a vision, looking at it from a point of treatment. So that's something what, we are very happy at Narayana Health, wherein we cater to all the strata of society, irrespective of their economic status. So, the government supported schemes, they're all basically in place just to ensure that nobody is, you're bridging the care gap completely. Nobody should have lack of access to uniform healthcare and uniform treatment. Once that is in place, the next important step that you require is you have to have a multidisciplinary approach. Oral cancer is something which is predominantly surgically treated, but that doesn't mean that we can negate the effects of colleagues from radiation and medical oncology. They are there because, you have advanced stage, and India happens to have at least about 70% of cancers which are advanced. So all these patients would need to go in through radiation and chemotherapy post-surgery. The role of upfront chemotherapy is very negligible, because that is going to be something what you can offer only in borderline resectable or in inoperable cases. You need to have each of these team members in place, because you need a patient coordinator who can actually liaise with the patient, ensure that they come back for regular treatment, ensure that you're looking into the finances, you're looking at basically the continuity of care. Most of the times, the enormity of treatment can cause them to drop out. Recovering from surgery and then going in through 6 weeks of radiation and chemo can be very daunting and challenging to the most educated also. So imagine yourself in a situation wherein you have come from a very different establishment, come to a tertiary care center, and looking at completing the whole spectrum of treatment. You need the expertise of imaging consultants, pathologists, the support groups with the counseling psychologist, speech and swallow physiotherapist, nutritionist, dental oncologist, palliative care, and of course, nursing. So it's basically got the whole support group. You have to have the support group in place, or you have to have like-minded people basically to be able to deliver treatment. The crucial determinants being time, diagnosis, access to healthcare, and of course, finances. So we at NH, with our basic science and translational research, have looked at oral cancer. So it started off with the work what Professor Moni Kuriakose did when he was here at Health City. So it started off with early detection, and we had this thing which was basically a mobile-based detection technology. It was basically looking at a few of the villages around Karnataka, wherein you use a smartphone. A smartphone is something which is accessible across the population. Use a smartphone, ask the person to just click an image and send it across remotely. So it goes to a healthcare provider, and he's able to look at the image and immediately tell you whether this warrants a biopsy. Because initiation of treatment would require the first step, that is, you get tissue diagnosis. Now, over the years, how the evolution of this has happened is they have looked at biomarkers, they have looked at cytology which is taken remotely rather than biopsy, because it's all going to be comparing it with the gold standard, that is with biopsy. So can you have some form of diagnostic technology which can be done remotely, which can be done at very far-flung places, and which can give us a diagnosis which can basically enable the patient to then go in and consult for relevant healthcare. So the key factor here would be diagnosis. If you don't have a correct diagnosis, as I showed you previously, you are again significantly bringing down the time for delivering appropriate healthcare. So instead of having a biopsy, because again biopsy comes in with the challenges of getting formalin fixation, with it getting interpreted by a certified histopathologist, can you just do something which was like a brush cytology, basically taking in from the equivalent of what the pap smear does? Look at biomarkers which have been validated. So now currently, we are in a system wherein it has gone from cytology to telecytology. We have got markers which have been proven, which can actually show with a reasonable amount of sensitivity and specificity, which are able to distinguish moderate dysplasia and carcinoma in situ, because these would be the two fundamental points wherein you would need to intervene. These would be the earliest points wherein you can expect that without having to undergo the extensive morbid surgery, there can be reversal of the disease, and of course, definitely good outcomes. Loss of fluorescence, looking at lectins as biomarkers are all things which are in the pipeline, which prove to be promising. So how do you take it to the masses? Now, when you want to take it to the masses, you basically require support from philanthropic groups, you require support from very big institutions. You need to enroll clusters, because you cannot have technology which has not been validated. You cannot have technology replacing the standard of care, replacing a gold standard. So the gold standard still continues to be biopsy. But how do you do this? How we have developed this is basically when we have been able to enroll big clusters, when we have been able to enroll big populations, and using screening as an opportunistic tool for intervention. So we have been liaising with, of course, the Biocon Foundation. We have got formal agreements with dental colleges like the KLE dental colleges, with University of Arizona. So by doing this, there have been opportunistic screening, which has been done. By getting in opportunistic screening, you're basically getting in big target populations, enrolling the clusters, and screening. So screening is definitely one of the proven tools, which Lancet has also definitely shown that can actually reduce the burden of the disease. So looking at these screening modalities which we have, which are generally non-invasive, you are able to detect and thereby prevent death when you're looking at it from oral cancer. So looking back at the natural biology, the three important things which need to be answered is there scope for intervention? Yes, there is scope for intervention if you're looking at it at the point of basically moderate dysplasia or high-grade dysplasia and carcinoma in situ. I'm not saying that the scope for intervention decreases as you go down the continuum of the disease, but then it brings in surgery, it brings in more forms of treatment. You intervene at a much more earlier stage. It's just probably restricted to excising the lesion completely and having the patient on a close surveillance. Chemo prevention, yes, it has a role if it is in the earlier stages. As it goes more advanced, the beneficial role of chemo prevention also comes down. And of course, reversibility. Reversibility is something that you can definitely look at only in the early stages. A person who has used tobacco needs at least about 10 years from abstinence from these carcinogenic agents before they can be reversed. So these are points which need to be looked at when you're trying to bridge the care gap. So the standard of care still remains surgery for definitive cancer cases, adjuvant treatment with radiation plus minus chemotherapy, moving on to targeted therapy, immunotherapy, and of course, best supportive care in the much more advanced stages. Now, the tenets of treatment again become affordability. So can technology give something in terms of affordability? So whatever point of care tool you have in terms of diagnosis, it should be something that is affordable, reproducible, and it should be something that can be basically even used by the healthcare worker. It should not require the complicated and, the expensive technology which we offer at tertiary care cancer centers. When you're looking at bridging the care gap, you're looking at getting care down to the grassroots levels. So you need to be able to have something which is affordable. The care needs to be standardized across strata. So that's something which we do at a hospital, wherein we are able to basically make sure that treatment is across multidisciplinary meetings and it is standardized. Services are equitable, it is comprehensive, and of course, you have got good patient and caregiver support systems. Now, what is remote-based care? COVID sort of changed it all, because 2 years of COVID showed us where we stand as a healthcare system. It gave opportunity that we need to talk with our colleagues in technology to develop healthcare platforms. People were very reluctant to step out of the confines of their houses and go to the healthcare facilities. So this gave an opportunity for healthcare platforms to basically look at how technology can improvise on healthcare. AI is definitely a key player here, and how AI would be a key player would be in terms of early diagnosis, in terms of imaging, whether you can actually look at imaging, radiomics coming into play. Can you look at getting interpretation and diagnosis? Can you look at biomarkers which actually predict outcomes? So healthcare platforms which are looking at these different in terms of either imaging, in terms of molecular markers, in terms of resistance markers, are going to be key change players. It's important that it has to be equitable and affordable, because other than that, it will be something which is just going to be in the pipeline, which will not translate into care. Risk assessment tools, normograms is something, and risk assessment is something which is going to come into the staging system. So risk assessment and prognostication would definitely be there. Investigations and consults have already gone on to a virtual platform, so you would not have concern about it. And most of the healthcare portals have got access to virtual tumor boards, wherein patients have an option of taking multiple opinions from well-established cancer centers and tumor boards. And of course, this translates into definitive care. So if you go back to the original the pathway of flow of treatment, this all signifies basically you're looking at comprehensive care being delivered in less than about 3 months. So this is where I guess technology would have a significant play. In advanced disease, it's very important that treatment has to be affordable, because advanced disease brings in the complexity of treatment. It's very important that the care has to be maintained. It has to be standard of care. And most importantly, collaborate for multicentric clinical trials, because this is what is going to give patients an opportunity to actually access treatment, which would have been there probably in the Western countries and in European countries, but also when they enroll onto a clinical trial, it gives them that affordability. So with this, I would say that, when you look at oral cancer and when you look at it on a perspective on World Cancer Day, we all know that the outcomes are going to be dependent upon the stage and diagnosis, because you've got the best prognosis and outcomes are with early stage. Economics and technology are going to definitely be a determinant, which will basically be helpful in standardizing care across all the healthcare facilities. Thank you very much.
Thank you very much for that wonderful talk, Dr. Vijay Pillai, sir, and particularly focusing on how do we sort of, bridge the care gap as such. Any questions from the audience to Dr. Vijay, sir? So meanwhile, just to just to get this started on the Q&A side, for oral cancer, typically, do you see more cases coming from rural because of the tobacco and things like that? For the urban case, what would be the primary cause that you generally see?
Ma'am, when you look at it, the number one risk factor still remains tobacco. So, whether it is going to be betel quid placement, or whether it is going to be smoking, or whether it is just, the chewing in any form of tobacco. Of course, alcohol has a synergistic effect. Now, HPV as a particular etiologic agent, if you look at it even across India, there were initial studies which were done at Amrita, which showed that HPV probably still remains oropharyngeal. it doesn't have a role when it comes to oral cancer. So other than any sort of risk factor, you just have to look at whether the conventional one, like whether it's a sharp tooth or whether it is any form of some very rare conditions, like something like probably Fanconi's anemia, which could have it. There is a school of thought which says that if you have it in a person who has got no habits compared to a person who has got habits, the outcome is sort of guarded. But there is a lot of evidence out there in the literature which says that, in fact, with close surveillance, the outcomes can be equivalent, if not better. The only thing is the delay in diagnosis, the issue that comes in with coming into diagnosis, because we always see that people who come in from remote villages and from the rural areas tend to come in a much more advanced stage. Unlike, educated people who would come in even for a regular screening. We see a lot of patients who would come in just because they would have seen it on social media that they're at a high risk of cancer. They just want a screening just to be sure that they're not having it. And very encouragingly, they would have quit the habit also.
That is very nice. Yeah. So I think, as you also mentioned, awareness that tobacco causes is known, but knowing more about early detection, and it was interesting to see that even 3.5 months and few weeks also can make a grave difference in the type of treatment we can get as well. Thank you very much, Dr. Pillai sir, for taking time to come in and educate the audience, educate all of us about the oral cancer, gaps, and how we can bridge that and make it really, really possible to fight it. Thank you very much, Dr. Vijay.
Thank you, ma'am. Thank you. It's indeed been a pleasure, and thank you, Charita, for having me. Have a wonderful day. Thank you.
Thank you, sir.
Thank you very much, sir. So now we come to Dr. Swapnil Sinha, who has kindly agreed to talk about cervical cancer, which is the second top cancer in women today. And welcome, ma'am. And we are very glad to have you as a part of the expert panel. I request Charita to give a formal introduction to Dr. Sinha, ma'am.
Thank you.
Charita.
Thank you, Dr. Gita. Hello, ma'am. Welcome to the webinar.
Hi, Charita. Am I audible to you?
Yes, ma'am. So
let me just, Dr. Swapnil Sinha holds MS in OBG from prestigious JSS Medical College, Mysore, and DGO from DMCH. She has been practicing for over 16 years with varying stint at institutions like Motherhood, Vaidehi, New Life, Ayuk Life Science, etc. She specialization in maternity and infertility, and is very conversant in dealing with all sorts of women's health issues. Let's listen to her on screening and diagnosis of cervical cancer and its prevention. Over to you, ma'am.
Yeah, sure. Thank you so much for letting me speak something about a very important problem like cervical cancer on this occasion of World Cancer Day, actually. There couldn't be any apt topic to be talked about being a gynecologist, actually. Now, the cervical cancer, as you know, it's a heterogeneous group of diseases which is characterized by uncontrolled or autonomous growth of cells which originate from uterine cervix. Now, the WHO has called the cervical cancer as one of the greatest threats to women's lives, and it is still considered a worldwide pandemic. And despite so many years, it's still considered a worldwide pandemic as of now also. So it is one of the most preventable and treatable malignant diseases. Now here comes a difference. Despite being such a bad form of a cancer, it is considered a preventable and treatable disease because it is a natural cause with slow progression, and it has a pre-malignant stage, and it can be detected by various methods and can be treated if detected early. So here comes the difference and the role of the screening methods which are impressed upon by everybody now and then. And it is the fourth most common malignancy in females worldwide. And in the developing nations like ours in India, it is the second most common malignancy among the females of India. So now it is estimated that around 30% cervical cancer cases will occur in the women who have never had a Pap test. And especially in a developing nation like ours, it approaches to as much as 60%. So nowadays it's very, we usually find the people who are coming into us for screening for the first time. They have never heard about cervical cancer, pap smear, these things, and they don't know what is pap test, right? So, and I wouldn't blame the patients for that. Even among the medical fraternity, not all of us get tested for pap smear, right? Despite knowing everything, and let alone the immunization part of it. So it requires a lot of awareness, not only among the patient, but yes, among the medical community as well. So the mean age for cervical cancer is about 47 years, and it has been found to have a bimodal distribution, which peaks at 35 to 39 years of age and about 60 to 64 years of age. Now, talking about the causes, hello?
Yes.
Yeah, sorry. I thought I'm like off. Okay, so talking about the causes for cervical cancer, the most important cause is human papillomavirus infection, which is there in about 99% of the cases of cervical cancer. So that human papillomavirus infection is mostly through sexual route, and it primarily affects the squamous cells of the cervix and the metaplastic epithelial cells, we can tell. And this HPV virus is a double-stranded virus, and it's at a protein capsid, which is unique for each viral type. And there are 150 distinct HPV types, out of which only 40 have been found to infect the lower genital tract, and around 15 of them are found to be oncogenic. So of those 15 types, type 16 and 18 are found to be the most oncogenic, 16 being the first one. And these two account for around 70% of the cases of carcinoma cervix. And there are the various high risk, intermediate risk, and low risk types of the HPV viruses. So the transmission, because of HPV infection, which is the commonest cause, the transmission is usually through a sexual contact, wherein the virus gains the access to the basal cell layer and the basement membrane through the microabrasions during sexual contact. So this is the main route of transmission, and the perinatal exposure, if at all, it can cause conjunctival, laryngeal, vulvar, and warts and all from birth up till 3 years of age. So the risk factors which we talk about are basically early onset of sexual activity, multiple sexual partners, those partners with multiple sexual partners. These all are related to HPV infection. And the early onset sexual activity, meaning that the immature cervix is more susceptible to this persistent HPV infection. Now, HPV infection is very common. It tends to happen, but it gets cleared in most of the cases. But in around 10% of the cases, it persists. And this persistent HPV infection is the one which can lead to over a period of time. And like through a long latent period, it can turn into pre-invasive and invasive stages. So the persistent HPV infection is something which we have to deal with. And apart from that, tobacco use, low socioeconomic status, meaning those people who have limited access to the screening programs, meaning that actually, and high parity, more cervical abuse basically, and immunosuppression, cigarette smoking, dietary factors, deficiency of folic acid and vitamin A also has been attributed to cervical cancer. Now, OCP, oral contraceptive use. So there is a different school of thought which believe that though cervical cancers, the risk increases around 4 times when we use OCP over a prolonged period of time. But it has been seen that those people actually harbor the HPV DNA, so they are more predisposed to that. Not everybody who is using OCP will become somebody who will have a cervical cancer in due course of time. But yeah, those people have a tendency to harbor the HPV DNA more often actually. Now then, talking about the natural history of the infection, infection is common after the onset of sexual activity. And yes, it spontaneously resolves in the adolescents and young women. And as I said, persistent infection is required for the neoplastic changes to occur. And the HPV virus type 16, 18, in them, if the persistent infection is lasting for more than 6 months, it can lead to low-grade squamous intraepithelial lesions. Now, the risk of progression to high grade, that increases with age. And also it has been found that the cell-mediated immunity has been found to play a very important role in the persistence, the progression, and the regression of the disease also. So there comes the role of immunity as well. So then most of the infections remain latent, and they remain in the quiescent stage. And depending upon how is the immune level of the patient and the age and all other factors, it can slowly replicate, and it takes a long time. And this persistent infection predisposed in those people who are a little predisposed can lead to pre-invasive lesions, and then followed by invasive lesions. So now the infection diagnosis as such can be done by NAT, PCR, or in situ hybridization techniques. But the main thing which we talk about is the primary prevention first, which we are more focused on. So now this vaccines, the HPV vaccines, which are now readily available at many places, and even the government has thought to implement it in the immunization schedules so that it is readily available to everybody. As of now, they are a little on the costlier side. They have a potential to prevent the malignancy at the 6 sites, namely cervix, vagina, vulva, anal canal, oropharynx, and penis also. And these are highly immunogenic, and they maintain the protection for around 8 to 10 years after the vaccination. So there are different types. They are bivalent, quadrivalent, or monovalent vaccines. So the bivalent vaccine is now no more used, which was called as Cervarix, which gave protection for HPV 16 and 18 types from GSK. The quadrivalent being the Gardasil, giving protection for 6, 11, 16, and 18 types from Merck. And the monovalent one is called the Gardasil 9. And this is gives protection for the types 6, 11, 16, 18, 31, 33, 45, 52, and 58. So these are the various vaccines available. And the target group for vaccination is around 9 to 14 years of age. Now, 2 doses are usually given for young girls who are less than 15 years of age, 0 and 6, actually, the doses. And the 3 doses, 0, 2, and 6, they are given for the girls who are more than 15 years of age. Now, this vaccine can be given to, especially this Gardasil, actually, can be given to both the boys and girls as well. The Cervarix was usually earlier meant for only girls. So, but then now this quadrivalent and monovalent vaccines, the Gardasil, is available for both sexes. Because the other, the males are also exposed to HPV viruses, and they can have this anal cancer, warts, penile cancer as well, and gives protection against that. Now, older women should be counseled regarding the reduction in efficacy, because they have been already exposed to some strains of the virus, and thus the importance of screening here is impressed upon. And a person who is HIV positive, that person also requires 3 doses, of course. And if we, many patients tend to ask that if we interrupt our doses, what do we do? Do we start again, or we complete the remaining doses? So it has been found that it is better to continue with the remaining doses, and there is no need to restart the vaccination. And it is not actually recommended in pregnancy, but if by mistake anybody takes the vaccination during pregnancy when they don't know whether they are pregnant, there is no need to impress upon them to go for MDP. Hello? 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 I think I lost.
No, we can hear you.
We can hear you.
Okay.
Yeah. We are able to hear you. We thought we were talking on you're talking on phone. Yeah.
No. I just muted it. Yeah. So yes. So in pregnancy, it is not recommended as such, but in lactation, it can be given. So this was about the vaccination part, and more people I have seen during the practice, they are coming up for the vaccination part, of course. But we have to inform them, because the people are not aware of what is the pap smear about, what is cervical cancer, why we are doing this test, and what is the need of vaccination. But when told upon, they definitely think about it. And when told that, okay, there is a vaccine which can prevent cancer among their daughters and their sisters and all, they are actually accepting it quite well. So I have seen in my own center the immunization going up for the same. Now, the secondary prevention, here the goal is to decrease the incidence and the prevalence of the disease by intercepting the progress from the precancerous stage, meaning the cervical intraepithelial neoplasia 1, 2, 3, which includes the dysplasia, mild, moderate, severe, and carcinoma in situ, to the invasive stage. So the interventions which we do in secondary prevention, they are counseling and the information gathering and sharing, basically, and screening for all the women to identify the precancerous lesions, which are generally asymptomatic. So the screening means we are dealing with those people who don't have any symptoms. So counseling becomes important because they are asymptomatic. Now, the treatment of identified precancerous lesions before they progress to the invasive cancer is also a part of secondary prevention. And even those people who have received the HPV vaccines, the screening should continue for them as well. So that also has to be impressed upon, that once you receive the vaccine, that doesn't mean that you don't have to go for the screening, because as told, if they are immunized a little late and all, they should continue the screening procedure because the efficacy can be different. And tertiary prevention is actually treatment of the invasive cancer, actually. So talking about the screening part in secondary prevention, the initiation, when should we start the screening procedure? We should start ideally from 21 years of age, regardless of sexual history and the other risk factors. Now, many people believe that if they're not married or if they're not sexually active, they should not undergo a cervical smear. But this is not the case. They should very much undergo a cervical smear and examination. And it should be told to them, because many people are unaware of this fact. And the interval, like how frequently they should be screened for around 21 to 29 years of age. The cytology means taking the smear should be 3 yearly, and from 30 years of age and above up till around 65, the cytology should be every 3 years, and the co-testing, meaning the DNA testing of the HPV virus together with the cytology, should be done around every 5 years of age. And so that is the frequency, the interval. And the discontinuation, when we should stop the screening, is above 65 years if their prior tests around 10 to 15 years back, from 10 to 15 years back, they're all normal and they were never at risk of anything. So then we can stop at around 65 years of age. So the cervical cytology, it detects in the most of the cervical neoplasia and the prolonged pre-malignant or in the early occult invasive phases. The specificity is high, around 98%, but the sensitivity is on the lower side, around 45 to 65%. So that is the reason why repeated screening throughout the life is recommended. So because of the low sensitivity of the test. And it comprises of PAP screening and liquid-based cytology. So there is a slide-based method and a liquid method, which is called a LBC or liquid-based cytology. And then there is an automated cytology as well. The other alternatives to cytology, apart from pap smear, is visual inspection under acetic acid called VIA, and villi, that is visual inspection after putting Lugol's iodine. So these things, they are very effective in low resource settings. So it has been found that though pap smear has high specificity and it is easy to do, doesn't require much of a training to the staff, even a nurse or a midwife can do it. But there are limitations to the availability of things. So this visual inspection under acetic acid and visual inspection with Lugol's iodine has been found to be helpful in low resource setting. Doesn't require much resources for that. So this, when we apply acetic acid, we can see this aceto-white lesions areas, and then they can be taken up from there. And similarly, Lugol's iodine, if we apply, there'll be some yellowish areas which are suspicious areas, and then they can be either we can take a biopsy or accordingly from there. So this has been found to be helpful in low resource setting. In high resource setting, as earlier discussed, we can go for either we can go for a primary HPV DNA detection, or we can go for a co-testing along with a pap smear and HPV DNA testing together. Now, it has been seen sometimes that in the primary DNA, HPV DNA detection, sometimes the transient infections will be there, and which usually will be cleared up in most of the cases. But it can cause a false impression of disease, so it can have little false positive rates on the higher side. So coming back to the pap smear, the way we should do it is we should avoid the menstruation part of the patient. I mean, schedule to avoid the menstruation. There should be no tamponing or douching or any intravaginal creams, or if there is any infection or any cervicitis or vaginitis or anything, that should be treated well before taking the pap smear. And the devices we use, they are, there's a spatula, which we call as Eyre spatula, and then there is a brush called the endocervical brush. And we can use a Q-tip also, and the cervical broom. So in case of a liquid-based cytology, we use a brush. And in case of a slide-based thing, we use the spatula and a broom, basically, a Q-tip. So regarding the co-testing, the co-testing is also used to diagnose the recurrent or the persistent disease, and it also determines whether the colposcopy is necessary. So that is the next step. If at all there is a recurrent infection or a CIN, cervical intraepithelial neoplasias, and then it is early detected, and there is a recurrent, or if there is a recurrent or persistent disease, then here the role of colposcopy becomes necessary. And colposcopy otherwise also leads to an early detection of any high-grade neoplasias as well. And this is an outpatient procedure, talking about colposcopy. And it's actually whenever we get an abnormal cell cytology, it's the next thing to go for, actually. And it's considered a gold standard in that way. And the primary goal for colposcopy is to identify whether it's an invasive or a pre-invasive lesion, and then we can take directed biopsies from the lesion. So if at all, if there is an obvious growth or ulceration or any cervix which is unusually firm and expanded, or any abnormal pap smear, then they should undergo, if at all it is very evident and growth, then the punch biopsy or a loop excision can be taken, and then histological confirmation can be done. Otherwise, if not possible, then we can always go for a colposcopy. And if at all in histological confirmation, if it is not found out, then the next step, we can go for a diagnostic conization, where we take a larger chunk of the tissue and then we do the histological diagnosis. Apart from that, the other non-invasive modalities are there, like CT, MRI, PET scan and all, which can help us to know about the disease in terms of the lymph node involvement, the spread into the parametrium, the tumor size and other stuff. So once found out in the early stage, because I would be dealing more with the early stage in the screening and the immunization part, as I told. So if we get to know about the early stages of infection and the disease, then the treatment can be done after doing the biopsy or the colposcopic biopsy or otherwise. We can go for ablation, actually. We can go for ablation or cryosurgery, wherein we use nitrous oxide, which freezes the tissues in contact, and the depth of destruction is around 5 millimeters. So, and we can use carbon dioxide laser, or we can do excision of the part. The excision can be like loop electrosurgical excision procedure, or a conization. It can be a cold knife conization or a laser conization. But the disadvantages of these surgical methods, the conization especially, is that it causes some difficulties, some problems in the cervix, meaning cervical stenosis, which can cause adverse pregnancy outcomes or preterm birth or a profuse discharge and all has been seen about the surgical methods for dealing with the superficial lesions. So that is mostly what I would like to talk. The symptoms of cervical cancer as such, when the patient comes to us and if he complains of postcoital bleeding or irregular bleeding or postmenopausal bleeding, very much increased vaginal discharge, a foul smelling vaginal discharge. So usually when these come, it becomes pretty late, as we can take them as a late stage or advanced stage when they have weight loss, fatigue, loss of appetite, swelling of legs and all. So it's very, very important to screen all the females in the from as young age as possible, 21 years being the age for the screening procedures, and educate them about the need for immunization. In our country, it is starting from around 11 to 12 years of age, the immunization, but in Western countries, it starts from 9 years only. So the need for screening and immunization throughout the life is very, very important, and treating the superficial or pre-malignant stages with less traumatic ways. And yes, that's mostly about it.
Thank you. Thank you very much, Dr. Swapnil, ma'am. I think it was a comprehensive view of
yes.
all the things that we need to know from cervical cancer perspective, screening and when it has to be done, how often. I think it was extremely comprehensive. Not sure if there are any specific questions for this particularly, but maybe as call for action, what we can say is early screening and mainly getting vaccinated at the age of 11 is very, very important. And so do you basically see women going in that direction of adopting vaccination? Do you see more number of women girls going in for that as well? Or do you see any hesitations? Or
Yes, ma'am. No, definitely they have a little bit of hesitation regarding the price part, as I told. They are like, okay, it is 4,000 per vaccine and there are 3 doses. So, okay, we'll come next time. But definitely when we are doing the screening, when we are doing the pap smear, and I think everybody, all the doctors, they tend to educate the patients that there is a vaccine as such, and it can prevent cancer because HPV is the cause in 99% of the cases. So it is prevented if you take the vaccine, and they are like, okay, my daughters can be protected from a very deadly cancer by immunization. So they are like, yeah, more and more they're accepting it. I have seen the cases of the people going for immunization rise in my center. So it's definitely acceptable now. Excellent. Yeah, and if there is introduction of if the government introduces this vaccine as a part of immunization schedule at low cost, it will be very, very helpful. I think that is the need of the
Absolutely, I think that prevention is definitely better than waiting for a cure. So absolutely, that's the way to go. Thankfully, cervical cancer has vaccines, whereas breast cancer, there's some early research, but still, many other cancers actually don't have a vaccine capability. So we urge all of you to actually, get your friends and families and daughters of those to actually go for vaccine. I think that's the best way. If not done, go for a pap smear regularly and possible HPV testing. And of course, if anything is wrong, then of course the doctors will take care of other tests that are needed. Thank you. Thank you so much, Dr.
Thank you, ma'am. Thank you so much for giving time.
Thank you. Thank you so much. So thank you, ma'am. And with that, we come to the end of the panel discussion, that we had arranged today. I request Dr. Collison to summarize the learnings from the different experts talks that we had. Dr. Collison, over to you. Dr. Collison is head of clinical research in Niramai, and he's an expert doctor with 30 years of experience in cardiology, but surgeon as well. Please, over to you, Dr. Collison.
Yeah, good afternoon, everybody. It was a very thorough and thoughtful discussions we've had from all of the speakers. So it was very good to hear Dr. Ajay Kumar's impression of what should be done in this country, especially since as he pointed out, the head and neck cancers and the lung cancers, we have the most number of patients. And so it is his dream and his vision that we should be the ones who are creating the protocols for these diseases, rather than, because in the West they have far less patients, but they are able to, with far less experience, make the clinical research in such a way that we have to listen to it. Whereas we are struggling in our country to make the adequate clinical research and the protocols, even though we have a whole lot of patients. So, but the point that we can be leaders in cancer care is something which we need to carry out, and support must be given to everybody, not just to Niramai. There are other people using AI in lung cancer and for cytology and diabetic retinopathy and various things. So the Indian developed products are very Indian specific and are definitely applicable to our country. So that should everybody should support these and use it and try it, rather than waiting for the publication in the Western Journal and the support and the guidelines from the West. So I think that was a very, very visionary statement by a very senior person in the cancer care, which just definitely holds the direction for us in the future. So obviously from all the speakers, we have understood that there is such a big screening gap in that almost everything from oral, breast and cervical cancer, all the figures are showing that still we are getting all the stage 3s and the stage 4s still in this, however modern we call our country and how rich and G20 and all of these things. At the end of the day, when we're looking at what greater good we are doing, we need to address this issue of finding cancers earlier. And again, using whatever methods are available. As Dr. Nayak said, it's not that there is one answer to one question. There are definitely going to be more than one answer to the question. And in the West, where there is no financial problems because of their rich economy and taxation system and healthcare funding, they answer the questions in different ways. The answers will be in a different way. For the rest of the world and for us, we also have to agree that there is the question is there, but there are many answers, and all of them are solutions. So understanding this will definitely reduce the gaps, whether it is cervical, lung, or even oral things. So in general, there definitely from this set of lectures, we do know the way forward. And as one of the speakers said, I think that was Dr. Vijay Pillai, the third limb of the Know It, Fight It, reducing the cancer gap is removing obstructions and obstacles, which are definitely come from the doctors, first of all, because whenever something is new, immediately they shrink and step backwards. Whereas, and the governments too don't want to change, or they don't know how to change. So they also unknowingly establish their barriers to adoption. So that will be next year's plan by the world bodies. So that is also very relevant to our company and to the fight against cancer.
Absolutely.
Anybody has a question, we can discuss.
Yeah, absolutely. Thank you so much, Dr. Collison, for well summarizing the different learnings we got during the panel. So the call for action from Niramai is definitely early detection and regular screening is absolutely important. Please, please, please take care of your health. And given that we are focused on breast cancer, I would like to remind you that regular self-breast examination, monthly self-breast examination is absolutely critical to detect symptoms, but do not wait for symptoms. We do at Niramai have also released an online breast health test, which you can answer a bunch of questions, which is available at hra.niramai.org. It's a free test, and you can take this test to actually see if there's any cause of concern, based on the different risk factors that affect breast cancer. Particularly, we will be extending this to other type of cancers shortly as well. This health risk assessment is also available on WhatsApp. This is the number 948-3434-444. So one could actually message any question, any breast health related question can be passed on to this. Just you can do it almost like you're chatting with your friend. Please save this number and ask any question, and we will answer if we know. Otherwise, we will get check with the expert and get back to you for any answer. This WhatsApp number can also be used to assess the risk as well by answering the questions, right? So this is one thing I wanted to mention. And of course, please do not forget that the thermalytics test, which is non-contact, non-invasive, can be done even before a symptom appears. It is a screening test, and you can identify which is the closest location. Just come to niramai.com. Look for register for screening, put your contact number and PIN code. Our team will get back to you with the closest center. We have more than 100, 200 plus locations, so it's not possible to list all of them there. So just say where you are, and we will come back to you in more than 20, 30 cities in India for sure. Thank you very much again. Please take care of your health. And we again thank all the speakers for giving their precious time to educate all of us. Thank you for staying on till the end. And thank you very much. And let us all spread this word, create cancer awareness, and awareness about early detection that is very, very needed, especially on this World Cancer Day. Thank you. Thank you for being with us. Thank you. Bye-bye.